In the collection of medical data, we will be able to build the algorithms for diagnosis. And if the women are not sufficiently represented, the tool will not be adapted for half of the population. And this data, the day of tomorrow, will fuel AI solutions. And finally, also in terms of governance and follow-up, we know that women are underrepresented. In this framework, we are all going to focus on what we call sexual and reproductive health and maternal and civil and child health, because these are real challenges for countries which have limited resources. Let us remember the data concerning maternal mortality. At the end of 2020, the WHO estimates that there were 287,000 maternal deaths, and 95% of which occurred in low and middle-income countries in sub-Saharan Africa and Asia. So there is an enormous gap, and a lot of efforts must be deployed to improve access to health for these women. What about the digital systems in all this? It may be a solution, but it can also be a factor of exclusion. There is what we call the digital divide between the North and the South, and between men and women. There are about 900 million women who do not have access to internet, and 2/3 of them live in low or middle income countries. So the main question is, how do we make sure that the digital solutions of today and tomorrow do not duplicate the existing barriers, but on the contrary, they enable us to fight against the barriers. They increase women's autonomy and to combat health problems. So these issues we are going to debate upon today, and as we are at the time of Nobel Prize winners ceremonies, Einstein used to say, if I had 1 hour to save the world, I would take 55 minutes to define the problem and 5 minutes to find the solutions. So saving the world is not possible for us today, but we can contribute to the definition of the problems and to advance our cause. I wish you all an excellent conference, as participative as possible, and I thank you for your attention. Thank you very much. Beatrice Garrett, Director General of the Pierre Fabre Foundation, and I welcome you all to this e-health conference, which is being held here in Lavore. Some of you have come from very far away, Asia, Africa, and Europe. So thank you for taking the time to come here. And welcome to all those who follow us at a distance on social media in French or in English. You can choose the language of your choice. And we greet the digital campus of the Francophonie University Agency. There's a lot of people gathered together all around the planet. A lot of people listen to us in Alexandra, Egypt, Yaoundé, Cameroon, Abidjan in Côte d'Ivoire. And special greetings to Tananarive in Madagascar, in Thailand, where students listen to us from the university. We will go to Lomé later on, to Lomé and Vassian in Laos, where all the teams are gathered together by the Pierre Fabre Foundation. For all of you at a distance, do not hesitate to send your question throughout today, your questions and your comments, or even to say hello. It's always pleasant to have greetings from Dakar, for example, or from Thailand. And you can bring your sunshine to us here as winter is coming. And this reminds us that we are an international community working together towards better access to health. This is the theme of today. How can e-health tools and digital systems can foster gender equity, more equity between men and women? The Observatory of E-Health in southern countries has encouraged a lot of initiatives in favor of women in terms of training, anything to do with maternity, sexuality, digital tools, pregnancy monitoring for the newborn as well. All this for populations that were very remote, in Nepal, for example. Today, the observatory wants to go even further on the way to improve all these applications. How can we make sure that we reach women really, while in many households it is a man who owns or who uses the mobile telephone? How to facilitate access to health services for women, because very often women come last. They put their children and their husbands first, and they do not always take time to look after themselves. So how can we avoid gender biases in e-health services application? Normally, algorithms are in favor of men. So you can see that there are a lot of questions on all these issues, and the more we develop digital tools, the more we'll have to try to respond to all these questions. So to start today, Renu Khanna, co-director of the Society for Health Alternatives, is going to take the floor. She is member of the advisory committee of WHO, and today she's going to give us an update on equity and gender issues.
Thank you very, very much. It's a real privilege for me to be here talking to you about gender and health. And it's a great opportunity for me to learn about digital health and gender equity in digital health with some of you who I recognize as global leaders in the area of gender and health. So I have 15 minutes, and I'm going to request you to warn me when my time is about to get up. The outline of what I'm going to speak about today is, as you can see, what is gender, how it affects health, what are some of the gender issues in health systems, and some reflections from my own practice from a community-based organization on what the potentials for digital health can be and what are some of the concerns. So, gender means different things to different people. For some, there is no difference between gender and sex. For many, it is to do with women and women's empowerment. And for others, it may be about gender identity, sexual orientation, or sexuality. However, gender and sex are different. While sex is biological and assigned at birth on the basis of our sexual and reproductive organs, gender is socially constructed. It is society that defines what it means to be a man or a woman in a given context, at a given time, in a given place. And there are other ways of understanding gender. Gender is fundamentally relational and applies to women as well as to men, in fact, to all people in a society. It concerns all types of relationships, economic relationships, emotional relationships, as well as the power that resides in these relationships. So gender is essentially, for me, about power relations, and that is something that we have to keep at the center of our analysis. Gender is also intersectional. Not all women are disadvantaged and vulnerable in the same way. Not all men are privileged in the same way. A woman professor, for instance, in a university in the United States has a very different set of privileges and vulnerabilities as compared to an indigenous woman, let's say, in Nepal. So, gender is structural. It works as a system. It is built on our reproductive bodies through social beliefs, gender norms for behavior, sexual division of labor, different activities and tasks for men, and activities of women are generally invisible, undervalued, and all of this provides differential access to and control over resources. And when I'm talking about resources, it's not just money or property, it's also resources like information, mobility, self-esteem, credit, control over technologies, and all of that. And it leads to differential decision-making and power. It's a system that feeds on itself, perpetuates itself. The beauty is that it can be broken. It can be broken at any of these subsystems. You can change gender norms for behavior. You can change access to and control over resources and all of that. So does gender matter in health? Both biological susceptibilities and vulnerabilities and gender affect health outcomes, and health differences for women and men exist beyond the sexual and reproductive health. Due to their biological, due to their biological and social standing, men, women, and LGBTQI people experience differences in their health status, in their exposure to risk and vulnerability, in their access to and use of services, their experiences in the healthcare facilities, their health-seeking behavior may be different, and the result is that health and social outcomes are different with great disparities. And here are some examples. More men die in road traffic accidents than women, and this is mainly due to gender reasons. Masculinity demands that men be adventurous, risk-taking, competitive. Gender roles demand that men go out for work and leisure. Division of resources gives men greater access to vehicles and mobility. There's another example of anemia. It's higher in women because of both biological and gender reasons. Women and girls menstruate and lose blood because of menstruation and in childbirth. And the gender dimension is that women several times in many of our contexts are the last to eat and eat only leftovers in the family. Yet another example of malaria. Both men and women are equally vulnerable to malaria, except pregnant women because of their reduced immunity. Malaria in pregnancy can result in obstetric complications, including increased anemia, which causes maternal deaths. Despite all of these risks, less than 5%, and all of this known facts, less than 5% of pregnant women have access to effective interventions. Several times, sex disaggregated data is not available nor used. This chart is, I don't know whether you can read everything, you obviously can't, but it captures for me, and this is from Lancet 2018, it captures for me whatever I have been speaking about in the last few minutes. There's a pointer here. So this, for instance, oops, yeah. Okay, sorry. So I'm not going to bother to use this because I don't have mastery over technology. But over here you can see this is the sex angle where the genes, the genitalia, body features, hormones is the basis of the social production of gender through institutions like the family, the community, through structures and policies which dictate the power and the norms which are bestowed upon men and women differentially. That then leads to the gendered social position, the intersectionality that I was talking about, which is based on your race, your class, your age, your ability, your sexuality, your location. And you can see men of a certain class are right on top, and the most below are the marginalized women, younger women, for instance. And all of this then leads to gendered pathways in health, gendered pathways to health, which show up as gender differences to exposure, gendered health behaviors, gendered impact on accessing care, gender-based health systems, and gender-based health research and data collection. And all of that finally leads to gender inequities and outcomes. And this happens across the life course, from childhood to old age. And another concept that's captured here is the concept of cumulative burden of all of these deprivations, which result in the embodiment of all of these disadvantages. So what are the gender issues in health systems? And here I'm looking at the 6 building blocks defined by WHO as the building blocks of health systems. Health service delivery is the first building block. Is quality and needed healthcare accessible to women and girls across their life cycle? Do trans persons and men receive the healthcare that they need? Does the organization and modes of service delivery acknowledge and respond to gender differentials in roles and responsibilities and access to resources and power? What about acceptability of health services, timings of clinic hours, spaces, for example, for privacy and confidentiality for adolescent health? What about provider-patient communication, especially for women from marginalized communities, for trans persons? Trans women with whom we work report facing extreme discrimination in the healthcare facilities when they try and access healthcare. Health workforce is a second building block. And is there bias-free working environment for women and men in the health workforce? Are health service providers trained in gender responsiveness? Do health systems recognize that women community health workers, unpaid care work, needs to be valued, needs to be recognized? Where are women in leadership positions? Even as principals of nursing colleges in my country, we found more men than women. Health systems, health information systems, which is what most of you are possibly concerned with. Can we readily get good quality sex disaggregated and age disaggregated data? Is it made use of at the point of data collection or only collected to be transmitted upwards? Are gender-sensitive health indicators monitored? What are the kinds of burdens of digitalization that health workers experience? Is it actually an aid and a support for their work, or does it add more burdens for their work? A recent study that I was reviewing in India was showing that the ASHA workers actually felt overburdened because they were maintaining physical records as well as digital records. And the women were saying that this is taking us away from our caring function. All that we're doing is recording. Medical products, vaccines, and technologies is another building block. Are essential medicines and devices available for women without stockouts? Medicines act differently on men and women. Our doctors taught this in the medical colleges. We saw in COVID, pregnant women were deprived of vaccines in the first phase of the pandemic because clinical trials did not include pregnant women. Health financing, because of high out-of-pocket expenses, women's health needs come last in most contexts. Households as a unit for insurance schemes means that women get excluded many times. This is something that Beatrice was talking about earlier. Many insurance packages have failed to include pregnancy and childbirth because they are not random events. So all of this are some of the issues, and this is, I'm just touching the tip of the iceberg. Leadership and governance. Are there processes and structures for participation of women in workforce like community health workers? Is there representation of women in decision-making fora? Do accountability and redressal mechanisms exist for the women service seekers? With over-medicalization and commodification of health, including women's health, resulting in increasing rates of hysterectomies and cesarean sections, we see this in my country, we argue that regulation of the private sector is really essential. I'm sure you're going to be discussing many of these issues related to gender equity in digital health. Beatrice actually spoke about some of them. There does exist a gender digital divide. Women's access to digital technologies is much less than men's. WHO is pushing for self-care for reproductive health. And while this is empowering and improving access, this is also a cause of concern for some of us in resource-poor contexts, because I feel that the state is absolving itself of its responsibility to guarantee essential health services. Ownership and privacy of data, I'm sure this is something else that you're going to be discussing in the coming 1.5 days. What does it do for women's autonomy and safety? Frontline workers' issues. I'm running out of time. And so let me just finish this. From our own work, we see that adolescent health and sexuality, the use of digital devices really leads to empowerment and citizenship building. And social accountability is, real-time monitoring of services is something which our young people and women in the collectives that we work with are doing. So what is the way forward? My suggestion would be that we use the gender and health analysis frameworks, including the intersectionality lens and the health systems building block frameworks, to evolve guidelines for promoting gender equity in digital health. Thank you very much for your attention. It's been really nice to talk to all of you. Thank you.
Merci, merci beaucoup.
Thank you very much, Renou. There will be, so there is a conference heard all over the world today. So I'd like to greet Dr. Boua in Togo, in Mali, encouraged by the Pierre Fabre Foundation, J.D. Kernou from the RDC, Lomé in Togo, Guinea is saying hello to us as well, and also Paris, Eric in Paris sends us his best greetings, and to Beatrice Garrett, the director of Pierre Fabre Foundation. We have an hello from the Congo, and from Bamako, the dermatology hospital. So hello to all the internauts. Please keep sending messages and send us your sunshine. We are now going to go to the ground after laying the foundations, and we're going to listen to players who are engaged with women and thanks to digital tools.
Et pour cette première table ronde, vont me rejoindre.
First round table, Misha Karwal, who is head of the Center for Innovation for Digital Health. Professor, please come. She's associate professor to the Health Medical School, Johns Hopkins in Baltimore. Please give her a big round of applause because she came from the United States to take part of the meeting of the e-health observatory, and then on the other side of the planet from Europe, Aparna Edge, who is joining us too. She's urogynecologist at the Hospital of Bombay, and she's still working there. She's working as a gynecologist. And then you have founded the NGO AMAD in India, who uses many digital tools to come and support pregnant women and newborn babies. We're going to come into detail into that in a few minutes. In duplex from Geneva, from the World Health Organization, we have Tagguer. I think she can hear us. She's a scientific expert, and she's going to tell us about a technical brief on artificial intelligence for opportunities and links for health. That shows really how relevant topics we are talking about are important, how important they are, because the World Health Organization is working actively on that. And then Caroline Perrin, who speaks, she's a German speaker, but her French is remarkable. Caroline, you're the executive director of Genie for Digital Hub. What is this structure in Geneva? Can you tell us more about it, please? It was co-founded with the agency, but the work is supported on the 20 years of implementation within different contexts of health. Thank you. You can tell us how you work to try to find proof of efficacy and non-efficacy for health in women. Aparna, I'm going to speak to you first of all. With the ONG you have founded, you work in India with mothers and their young children, and 2 children are really dying. 2 children age of less than 5 years are dying every minute in India. Pregnant women can not have the right follow-up in terms of health. Sometimes it's just a lack that hasn't been detected in a pregnant lady, so that the pregnancy doesn't go well, and you have social and medical workers who go at the women's places. I mean, it's very easy. We have images here, and it's good to see what it looks like in real life. Those social and medical workers, they have digital tools with them. They have also a telephone platform, and you have WhatsApp loops or information for women. So I won't say it's wonderful, but many other NGOs are proposing this kind of tools in their countries. But your difference is that your tools were designed for women. What does it mean concretely that they were designed specially for women, digital tools for women?
Yeah, the way we work is that we have a very grounds-up approach. Community
En fait, c'était conçu au départ avec cette
Around the constraints of the women. So we had, so on the one hand, we have a voice calling service that handholds women through pregnancy till the child is 1 year of age. And the other hand, we train health workers through the health system. And we are through the country. We have at least 50 million women. Now, the thing is that the earlier we would kind of work around the constraints that women faced on the ground. But what we realized was that it is not just enough to give information. It's so important to also understand the social and cultural barriers that prevent the women from exercising the behavioral change that we are espousing. And so when we went in the field, what we did was that we recognized that we have to actually now get the male into the system. Our content has now become gender transformative because the woman is not a decision-making entity in the family. It's the husbands and the mothers-in-law who exercise the control. The women, we inform them, but they're not able to kind of act on it because at the time of decision-making, the husbands decide what will get done and not done, right? So now what has happened is that it's actually the women leaders in our team that understood that we have to make a gender transformative format that now the family, the husband and wife together are the ones who we address in our content. They are the ones who, work together to make the decisions for themselves and their children, and they bring their other family members into the conversation. That's how we've transformed our content over time. So the men don't get involved only when there is, a crisis. They are engaged from day one. They are involved in the continuum of care, and also that they ensure that they engage with the wives in shared decision making. That the husband and wife together, decide for themselves and involve others when required. So this came in only because of the fact that we had, a team involved women who understood the constraints in the field because they were facing the same constraints. The field force who were engaged in the content creation process came up with this understanding from the field, and that led to this change, which is gender transformative. And this has now been adopted by the government of India now. Yeah.
On entend bien dans vos propos justement l'importance de bien connaître le
to know the context, the social context, what we have to do before we imagine the contest, whether it is the answer, whether it is a technical or not. You're saying that to understand well what's happening in the field, in certain communities, it's very important to have women who are talking to other women, because in some communities, women will not answer to social workers who are men. They're not going to give all the information. Can you confirm this?
It's beyond just that the women would not. Yes, it's beyond just that the women would not talk to men. It's about the fact that inequity plays a huge role in access to healthcare, right? So when we started off with health-based solutions, mobile health-based solutions, it was an equality-based lens. You have one program that goes to everybody. But what we recognized was that there are subsections underprivileged in India, being underprivileged in India. Like if you're a scheduled caste, scheduled tribe woman, if you're a Muslim woman, if you're an adolescent mother, you're a migrant mother, your access to healthcare is severely limited. And if technology does not design for this inequity, you're actually going to worsen the inequity. Right, so we have solutions where we train health workers right through the health system, but they would not even approach scheduled caste, scheduled tribe women because of the hierarchical nature of caregiving. Migrant mothers are not tracked from source to destinations. So and Muslim women, there are a lot of difficulties in reaching out to them because they don't have trust in the health system. So what we are doing is to actually build systems, lateral approaches to these subgroups. So why not get every village has a self-help women's group. Why don't we use those groups to reach out to scheduled caste, scheduled tribe women, because they are from the same community and they understand the constraints. Same thing with Muslim women, right? We're getting in culturally nuanced content that speaks to them, involves community leaders and peer groups within the Muslim community. Same thing with adolescent girls, right? So it's very important to have adolescent health champions, who communicate with the adolescent mothers to ensure that they get they listen to the information and content. So we are adopting lateral approaches to these subgroups. Yeah.
Vous citez à plusieurs reprises.
You're quoting two words that are really key, everyone know, which is information and content. You're talking a lot about that. Of course, you're saying information is empowerment. Of course, that gives empowerment to women if they get the right information. If we talk about content, so that we understand really concretely, what does it mean to you, a content that will be designed by women, for women, to allow them for the information to be conveyed? Is it only written by women, only with a gender biased, woman biased?
We have men, in fact, we've got the male voice in. In fact, we're evaluating how men, respond to the content, and we're ensuring that, their involvement is assessed along with it. And the first part of your question about information is empowerment. This is something that I really learned along the way, right? As a typical doctor, when I designed Arman programs, as a doctor, you give information, you expect them to remember it, act on it, exercise behavioral change, we use the technical terms, and then there will be improved health outcomes. And what I realized in the field is that, the women have it within themselves. They're very smart. These are all women who understand, have a sense of justice. And what we actually able to do is that when you give them the right information at the right time, they're able to, it ignites that sense of, knowledge, like the justice within themselves, and they go beyond what you expect. I'll give a small example, right? In the slums of Mumbai, there was this Muslim girl who was the wife of an Azan preacher, right? And she got pregnant, and during that pregnancy, she didn't get our service, the voice calling service that handhelds women. And then she got pregnant again within the first 2 months of delivering the first child. And she knew that there's something wrong, that you have to have spacing. Internally, she knew that it was not right for her body. And when she spoke to her husband and in-laws, they didn't agree, But then Mitra, our program, which supported the woman, came to her. It spoke of spacing. It spoke of family planning. And it really ignited inside her this sense that, yes, I was right. So she convinced her Azan preacher husband to adopt family planning. Right? And same thing with, examples of women who've given up wearing a veil, they've sent their daughters to English medium school. So this information goes beyond what we are actually talking about, is intergenerational change. Yeah.
Smisha, je vois que vous aviez envie de réagir à ce que nous raconte Aparna, qui vient du terrain. C'est vrai qu'on a souvent soutenu...
Do you want to react to what Aparna said? We have supported many technical solutions, applications. First of all, it was a technical bias, but Aparna tells us that it is a sociological aspect that is very important. The application, the way it is built, is it going to reach the public it is supposed to be reaching? It's part of the themes that you're studying at university.
And yeah, absolutely agree with Aparna and the work that... with Aparna and her perspectives. So first of all, I think increasingly women's access to technology...
On va peut-être just change the microphone. I suppose that there are some interferences. If you can take Aparna's microphone, please.
Thank you. That women's access to technology over time is increasing. It's still not equitable. So on average, women are about 15% less likely to have access to mobile phones and internet connectivity than men globally. And but it is improving over time, and the gender gap is decreasing. But access to technology in and of itself does not address the social and the digital determinants of healthcare, which is what Aparna is speaking to. There are some fundamental structural barriers in access to services that are deep-rooted in the culture of every community, of every country. And the programs that we undertake, digital or not, they must actively address those. So in the case of Arman, ensuring that the images that are used represent men and women, because in India, in the context of India, often the decision-making capacity is within household elders, within the men, whereas the pregnancy is largely experienced by women. And so how do we bring them into the experience of pregnancy? How do we bring the men into the experience of pregnancy, as Aparna said? The use of imagery, the use of voice, whose voice are you using? The design of the digital intervention must address that, and that only speaks to the knowledge. Then there is access, right? Even if you are able to convey the right knowledge, people may not actually get to services because it requires transportation, requires financial independence. And how do we address that barrier? And then even when women do get to services, or even then when people do get to health services, there are other barriers to consider. So just noting that it's not just access to technology. We often limit ourselves there, but a gender transformative approach, as Aparna is alluding to, really entails addressing the ecosystem of which technology is a small part.
Smisha, une autre question pour prolonger ce que...
Another question to understand what you're saying and to go beyond and to get away with prejudices. We thought that if we had applications on mobile phones, we would get directly to the end user, in your case, woman or young woman, and that we could talk about everything and address all messages and all news to these final end users and all medical results, as imagining they will all receive the information on their mobile phone and that it will be confidential. But we can see that certain messages are complicated to convey, are complicated. I'm talking about IST, of abortion, of HIV, and different news for the woman who's pregnant, and she doesn't want this information to be propagated around her. She wants it to keep it for herself.
The issues of access and privacy and security must be considered in designing digital interventions. There is, in fact, there is a lot of health information that should be private. But if mobile phones are owned or if they are shared by different members of the household, privacy is, of course, questionable in that case, especially when health information is sensitive. So there is some evidence that in cases where sensitive information is shared through mobile phones, there is increased likelihood of domestic violence. And so, and that might have to do with the nature of the information. And so there is a need to be cautious and I think there is a reason to pause and say, is mobile the right interface, right? Because in some cases, depending on the context or depending on the type of information, sending information as text messages or as voice messages may not be appropriate.
Aparna, vous développez très fort.
Aparna, you're developing a digital strategy. You've been doing that for many years. You have call centers, of course, where women can call and ask for help and ask questions. But you've been supporting also, and we have supported Assiatou in Africa with call centers to answer often young women about, they had questions about sexuality and reproduction. In the northern countries, of course, with applications and mobile phones, we're going to really have access to many, many people in much quicker way, and then you don't need call centers anymore. How do you think you could balance your strategy between the voice, the call center, and the digital? What is the percentage, you would say, of the one and the other? Yes, what the question is, call centers might disappear because now you have applications directly sent and text messages sent directly on mobile phones. So what do you think?
We were a voice-based service. In India, SMS would not work because women can't read an SMS, open SMS. And, we started Arman, but it was always voice-based, where we sent automated voice calls, hand-holding women and health workers. And we had a call center for additional support, for two-way communication. But now, because smartphone usage in the country has really spread, I mean, in tribal Jharkhand, I would like you to come and see how 70% of households have access to a smartphone. And now we're using multimedia approaches and two-way communication. So it's a video format, because our preliminary research showed video works the best. People really like to imbibe information where they can actually watch for long. I mean, and what we have created now is a drama format around one family, which is followed over time through pregnancy and infancy. And so the families can learn by introjection. You're suggesting subtle behavioral changes, which is adopted by the family. And the way it is actually going to be is that the video goes across, and then there'll be a little quiz. And they'll be surprised how women in Jharkhand are responding to the quizzes and answering questions. So why the quizzes are important, because it allows two-way communication. They can give feedback. We can understand how much they've understood. And are they even exercising those behaviors? Because say, for example, iron supplementation, we can follow them over time and then ask them, are they really taking those iron tablets? And based on the answer, we can send an affirmative moving poster, or we can talk about, if you don't exercise these behaviors, what can go wrong? So it's an interactive thing. And also we're integrating AI. So I'm very happy to say in Uttar Pradesh, so we have with women and with health workers, right? So we train health workers at every level of the health system. So the protocols we've created a Gen AI-based, help desk, which has been taught those protocols. And so when the ANMs, the nurses ask questions, we have a stratified system where the Gen AI can answer because it knows the universe of the content. And then if there is anything, then the live person can get in when there are more complex things that can't be answered by the Gen AI. So we're going on to the stratified approach, which is making use of all the digital tools. I'm very happy to tell you that it actually works in the most rural parts of the country.
Misha et Aparna, quand je vous écoute tous les...
When I hear you, Aparna and Misha, I realize all the possibilities one has for communicating and to reach people who are really huge thanks to this digital tool. And artificial intelligence multiplies the spread and the risk. Temre Samrat, who is with us live from Geneva, Tyers Samrat, thank you very much for being with us, Tyers. The World Health Organization just is talking about those topics for AI and the effect for reproductive health. And you're doing the synthesis of 12,000 studies to compare, see how relevant the tools are, the risks they convey. Can you please give us a few examples of tools you're analyzing to see how diverse those digital tools are? Can you please tell us?
Me here, and it's been an honor to be alongside other panelists. So AI, as I think all of us know, has been a big buzzword over the past few years, and it has huge implications in sexual and reproductive health and rights, because partly, as was mentioned, it's a great way for people to access information. There's a lot of stigmatized issues or issues that people may not talk about publicly or easily access services on, such as family planning, STIs, even pregnancy care and other issues. So, we've been seeing a rise in chatbots, not necessarily AI specific, but more recently because of Gen AI, as was mentioned by one of the panelists. We've been seeing a huge increase in the development of chatbots so that individuals, particularly young adolescents, people that are seeking information can, have some perceived an anonymous way of being able to access information. There is still potential around misinformation or not having complete information within these chatbots, but I think the technology is really advancing. And as was mentioned, digital devices are now in more people's hands than ever, and it's actually a really great way to be able to provide information, access to services, if it's done correctly and appropriately and with all the contextual considerations. Another big area that we're also seeing is in being able to analyze ultrasound images. So this has been done, I think, a lot with telemedicine, being able to share images back to people that may have more skilled professions and being able to analyze ultrasound readings in maternal health. But I think now there's increasing experimentation we cannot definitively say what, the trend that these things are going in. We still need to do our research around this, but we do see huge trends in trying to address a lot of maternal health complications using either images generated from ultrasounds and having AI systems and tools be able to analyze it at a much faster rate, or to be able to access, to do it with similar clinical precision. We're also seeing, oh, yeah. So,
Yes.
and then the last part I'll just mention is we're seeing a lot of use of personal health record information to be able to understand potential risk factors, to be able to potentially target interventions to those that may have, particular needs or risks for complications. So this is what we're seeing. We still have to wait to actually see whether there's impact coming out of this. Thank you.
Tagguer, je voudrais vous poser, si vous me le...
Tagguer, I want to ask you 2 questions. You spoke about chatbots, and they are very present in the study, in the technical brief you are sharing with us from the World Health Organization. And then it is a wonderful tool, the chatbots, to answer massively to mass questions, but be cautious because we have risk with the answers we send to young people. I'm a bit naive, but I thought, who is going to give fake answers and to say to chatbots to give fake answers for young population? Who would think about that? Can you please tell me more?
Thank you. Yeah, so there's 2 ways. I mean, there's several ways this could happen. One is what we call misinformation, which is that maybe the chatbot could have hallucinations, which is, it thinks it's giving you the right information, but it may not provide the right information just unintentionally. So there's that aspect of misinformation where it's not, actively lying, but it may think it has the resources. And if it's particularly with generative AI, there are these things where it thinks it has retrieved the right information to respond, but it's not really correct. And you really have to make sure that you can decipher what is true, what is correct and not. And so there is that risk for people that don't know enough. This happens to me even with ChatGPT. You can get something that doesn't actually correspond to what you were looking for. And that's what we kind of call hallucination as well as misinformation. On the other hand, there's also something that we call disinformation, and that is where there's intentional. So it's not just an error or a bias in how the information is coming out, but the disinformation is where it's intentional. So this could be because of areas like sexual and reproductive health, where there's also politics around abortion and other sensitive areas. There could be potentially an intention to want to dissuade people to say, oh, this population shouldn't be using these types of methods, when, and just intentionally putting that out there because of other beliefs that are there. And, as was explained earlier, the social and cultural dynamics and ideologies that may be there. So we have to distinguish between the misinformation and disinformation, one being intentional and one being just unintentional. Maybe the system hasn't been advanced enough. But all this to say that in sexual and reproductive health, I mean, there is a lot of different thoughts. Should adolescents be using certain contraceptive methods? No, yes. And so there could be a way that the system is designed where it's kind of intentionally misleading the outputs that could come out of it.
Ouais,
As an
passionnant.
example.
Ouais, passionnant ce que vous nous dites.
It is passionating what you're saying to us, but it is frightening to think that chatbox answers massively to thousands of young people and 100,000 and millions of young people. We don't know what the intentions are. Ideas with a contraceptive method. They give disinformation and fake news, and they say that if certain contraceptive methods will make men sterile, for example. So what about safety of data that are collected from women? You're reminding us, reminding states, NGOs, big actors and stakeholders to have the right intention. Not just the South countries, but also North countries. Data can be sold, and we have to be extremely careful because it could be really disastrous for women.
It's we shouldn't throw, as they say in English, the baby out with the bathwater. There's still a lot of great advantages to being able to potentially access information in this way, and if it's as well accompanied by other interventions that can really ensure that people are getting the services and it is being impactful. But there is, particularly I think in the high income countries, maybe there is this risk of wanting to use the data to be able to sell it, to be able to commodify and, maybe use it for other marketing purposes. It could be used to market pregnancy tests or other things like that. Or it could be shared with others and people not having the awareness of where their information is going. I think, AI is largely powered by data. And so we need to really think about how do we also ensure that there's protection of that data. But I think, these conversations are happening, and it's good to see that there is more thought happening in this space than probably even a few years back with legislation.
Et ceci, voilà bien sûr ce que vous rappelez dans le Nord comme dans le Sud, hein, qu'en France, une grande société aujourd'hui.
And that is valid for North and South. We have recently 800,000 euros penalty. A company had this penalty because it sold data without making them anonymous. So there's a real risk. Parna, you wanted to talk quickly. Misha.
Thank you, Lionel. I actually just wanted to clarify a comment that you made. I think there is a difference between fake news, health programs, and health-focused conversational agents or chatbots that Tigist was mentioning. They do not spread fake news. Not typically. It would be an anomaly. So I think we want to be careful of creating information, of seeing this as threatening. Most health programs have some level of regulation where hallucinations are very much actively being thought about, and there is very much consideration for what the chatbot is responding with. In fact, most health-related chatbots are not AI-based. They are, in fact, they understand the input based on the use of AI, because what it has the potential to do is change the power dynamics, right? Parna started with saying that as a doctor, I'm told what to tell the patient, right? And the doctor decides what the patient learns. A chatbot helps reverse that power dynamic, where the patient can ask freely in the privacy of their space what they would like to know, right? What they would like to know. They can ask in their normal language. The chatbot can understand that because of AI. In most cases, the responses are not AI-based. They are vetted, like in the case of Arman, right? They come from a library of responses, and so they are not just telling you you'll go sterile or some, such information like that. They are vetted and they are appropriate responses. So just want to be careful about how we are presenting this.
Yeah, effectivement, il est d'autant plus important de bien classifier.
And it is very important to classify things very well, to have the right classification. Aparna, very quickly.
For example, in our Gen AI chatbot support, the universe of the content is very clearly defined by us. We created the protocols, and the chatbot takes the content only from that universe. And it's verified information completely, so it's not misinformation, and the hallucination is not there because of the fact that the universe is defined. And then obviously, it does have a library of answers. It also can create its new answer, but then it's verified by a live person sitting behind, right? So there are all these checks and balances in place. Yeah.
On voit derrière toutes les précisions. Hein.
One can see behind everything you're saying, behind what the World Health Organization technical brief that is coming out to really classify things and to prove the efficacy of the digital solutions.
d'évaluation, Caroline.
So in terms of Caroline Perrin, within your organization, you're really following the implementation of digital health solutions in South countries. And you can see that we lack hindsight and feedback in terms of data to take the right decisions to develop those digital tools. So just launched very recently a very important study on remote health systems in Mali and in Nepal. Can you tell us what systems we're talking about? Why did you do this study?
In Nepal, we created a telemedicine and tele-expertise network. That is to say that we connect doctors or nurses, health professionals that are in primary health care in rural areas to specialists in hospitals. So it's not a connection between doctor and patient, but it is between doctors and specialist physicians. So it makes it possible for professionals in rural areas to be connected, because traveling around can be complicated. Even if it's only a few kilometers distance, you can take several hours. We've been doing this for several years, for a long time. And in Nepal, we have noticed that the number of women in telemedicine has increased. We have observed that there is a need now to carry out a scientific survey with data that will make it possible for us to make decisions on this. So it is important to analyze the role of telemedicine in rural areas to improve access to healthcare, but also, does telemedicine improve everything? What is your theory? What are your hypotheses that make you conclude that women are more numerous and women use these services more? Perhaps the study will show that there is no difference, but in any case, with the retrospective data that we have, we can see that a lot more women consult. It is a facilitation for women to have access to health services. Women, through telemedicine, can be connected to hospital. And this is a nice, good way for women's access to improve. Indeed, this can be a good way of proving that this service will be good for women. When you launch this study, you said this study is extremely complex because data collection about women is complicated. Well, it's not so much data about women, but generally speaking, when you work in digital health, you know that we still lack a lot of data and evidence, but it is also easy to do. We also have methodologies in place, but it is complicated because in maternal health, for example, for women, sometimes we need to wait for 10 years before we can see results, and then the project has disappeared. And there's a practical side of it as well. Health professionals are overloaded with work. We have to recruit more people to collect data. We had recruited men and women for this, because men didn't want to answer questions when it was a woman asking the question. There's a lot of complications of this nature, and that is a reason why probably we need to do a lot more, where we can see with you the difference between what we can imagine in terms of digital applications and then the field reality. It is interesting. You carried out other studies on other subjects, on diabetes, for example, the risk of diabetes in pregnant women. And already then, you had questioned the distance tools, the telemedicine tools. Well, as I said before, there may be complications because some women asked us not to send the results because very often it is a man who has access to the telephone, and the wife, the woman, doesn't want the husband to know the results. It is not the fault of women, but it is a cultural reason, and it is complicated. So when we design solutions, we must take into account all societal aspects. Bisha Gawal, we can say that data collection, the collection of good data, good information is absolutely crucial. It is difficult, but you say that if we limit the data to the fact that we are talking to women, we can get it wrong. And you insist on the notion of intersexuality that has to be taken into account. What is this notion of intersexuality?
Intersectionality is the idea, and I think Renu in her opening remarks described it really well when she said that just our gender does not determine how we experience the world. As a US-based professor, the gender dynamics that I experience are very different than who I was. I'm not disempowered, right? But when I was in India as a social worker, it was a very different gender dynamic and environment that I experienced. So it's not just our gender, but a combination of a multiple factors that really determine it. So when we are gathering data, often in the digital space, it remains about women's access to phones. But a upper caste woman in Renu's example versus a different caste woman who are considered lower on the spectrum in the Indian society, their access, their financial capacity, their literacy, everything matters. All of those factors determine how they experience the healthcare sector. And so as we're thinking about data, continuing to gather information about digital literacy, socioeconomic status, educational attainment are all important dimensions which even within the same gender affect people differently. And that's the intersectionality.
Aparna, vous souhaitez compléter?
What was the question?
Yeah, vous vouliez
Would you like to complete what Ms. Misha has just said?
Yeah, but one more thing I want to talk about data collection from the gender perspective. And this is something I've learned as an Urban founder. You know, when you have child health, we used to look at child health data overall. We didn't stratify based on data. You mentioned it. And I was so ashamed of it, right? Later on, we realized that more girl children suffer from chronic undernutrition than male children. In our programs, we are now tracking that. Unless you track that data, you're not able to go and improve your data, right? So we're tracking how the girl child does with respect to the male child. We look at the nuances or determinants of their lack of access to care. And that has helped us improve our program tremendously. But it didn't start off like that, you know, and it's a learning process for us also. The gender plays such a big role in. And also, like I said, earlier, when talk of gender-based data collection, we would only speak to the woman earlier. When we were doing our evaluation, it was only women we were asking questions on behavioral change. And now we realize that we have to speak to the husbands and the family members to understand the reasons for lack of adoption of behaviors.
Aparna, ma toute dernière question, mais je voudrais qu'on reste un tout petit...
My very last question, Aparna, for you. What about men in all this? What do we become? What is of us? Men, do we have to leave the room? Do we have to become invisible? Or do we still have a role to play?
Role to play because of the fact they are the ones who actually hold the decision-making key. So one thing is, earlier, the way we are transforming our programs is that earlier, they were the ones who were just coming. They were disinterested partners. Maternity or child health was a woman's domain. It is not a male business. But then they would come in when decision-making was required, when there was a crisis, like heroes. But the thing that has to change, and that's what our content is moving towards, is that it's a husband and wife together who are pregnant, is the child is both of theirs. And also, they have to be engaged in the continuum of care from day one. Right. So, and second thing is that the husbands have to also understand that the wives have to be partners, equal partners, the shared decision making. So the content, the way we have got a kind of device is that by introjection they learn how to involve the wives in that shared decision making process. So it's a husband and wife together who decide for themselves and their children, and then involve the family members as and when required. So then the primacy of the woman and not the mother-in-law, becomes, Yeah, and third thing that we're doing, it's also a patriarchy thing, right? A lot of the women have imbibed those patriarchal gendered norms. So the mothers-in-law, the way they behave, and in media always stigmatizes those women, right? If you look at Indian media, the mothers-in-law are stigmatized, right? It's very horrible, right? It's the way they talk about the very bad mother-in-law. But then what we've done in our content is to have an informed mother-in-law who's involved, and who actually helps the husband and wife in their decision-making process in a very positive manner. So women will learn by introjection. And mothers-in-law would like to be like that mother-in-law.
Et si j'ai bien compris,
So if I understand well, this perspective, associating men a little more in this gender transformative process, it is something that you've seen for a few years in your country? It is a novelty?
A novelty, and I'm very happy to say that we run Government of India programs. And just last 2 weeks ago, we got the permission for this content to go through the country. And in a patriarchal country like India, to have Government of India programs speak this language is a very big deal. It's been so heartening. It's at the basis of all, that we need to do in the gender work. Right? There's a long way to go, but it's great that the Government of India has accepted it. Yeah.
Merci à toutes les quatre.
Thank you very much to you all. Stay with us. I think they deserve a round of applause. We can see that it is important to go on the ground and to to do the last mile to understand how digital tools can be developed. If you have any comment, any question, please prepare them, send us to them in writing if you are at a distance, or if you're in the room, we'll pass a mic around so that you can ask all your questions to our guests. I suggest we go to the other end of the world, to those who are listening to us from very far away in Laos. Chan. Chan is a coordinator in Laos for the Pierre Fabre Foundation. I hope you can hear us. Chan, can you receive us? What time is it for you? And what's the weather like? Make us dream. What time is it and what is your weather like? We can see you, Chan, but we cannot hear you. I think Chan has gone to get another mic. I don't know whether we'll be able to establish the connection because Chan has disappeared. Well, we'll come back to you in a few minutes when the connection... Hello?
Hear us. Bon, on vous retrouve d'ici. Okay. On a un petit souci avec votre micro.
We have a sound issue. We'll come back to you in a few minutes to see if you have any questions to ask our guest speakers this morning. Madam, who would like to ask a question from the room? Are there any questions for our guests? Jai.
Parna, very heartening to know that Government of India has accepted your Arman program. So what it takes for you to actually scale this up pan-India?
So we, from the time of inception of Arman, we realized that it's very important that we work with the government health systems to achieve true scale and cost-effective scale. So the way we have our programs is a co-invested public-private partnership. Government funds the program and the scale-up, and we fund ourselves, because unless we fund ourselves, there won't be any innovation and augmentation. So the way we worked actually is that we started off with our own program called Mitra, which is a voice calling service to women that, through pregnancy and infancy. And we went to 3 million women in 9 states, and the government of India noticed the success. In 2018, they came to us and asked us to take over their program. It is a similar program called Kilkari, and the idea was to innovate and augment it. And then COVID struck, but I'm very happy to say that the augmentation plan is in place. And now we are going, so the thing is, in the digital space, you have to keep pace with the changing norms of technology use of the women and families themselves, right? So, India has become, the spread of smartphone is significant, right? It really allows two-way communication and multimedia approaches. So we've got the permission to go ahead and do that. And now we are going to have increased emphasis on high-risk factors in women and children and equity encumbrance. So if you've got a high-risk factor or equity encumbered, I spoke about the 5 subdivisions like scheduled caste, scheduled tribe, Muslim women, adolescent mothers. And we are hoping to have increased targeted approaches, lateral approaches, two-way communication, hand-holding for that inequity or risk factor. So, and it's with the government of India. Same thing with the health worker training. So we work with health workers at every level. The ASHA training program in the country, we run the mobile health-based solution. So we've reached around 50 million women and trained over 414,000 health workers in 20 states of India.
Oui, Jai, on vous apporte un micro pour la traduction.
Yeah, it's a connected question. I was expecting this localization because India is like easily 30 plus countries put together.
Yes.
L'Inde, c'est comme une trentaine de pays chez nous. Et donc, il vous faut, et plusieurs langues également, donc il vous faut vous adresser aux patients dans leur langue.
Right? It's not only the language, so even different languages, and in fact, many dialects. So if you look at Madhya Pradesh or in some of the bigger tribal languages, we have it all translated. And also when it goes from one state to the other, it's not just the language, the cultural nuance, the myths might change. So all of the content speaks to all of that. And like I said, for Muslim women, we also have culturally nuanced, content that speaks to their cultural influences, etc. So it's very tailored to the ground.
Je prolonge votre question, Jai, jusqu'à Genève.
I asked your question to Geneva, the question of the language, the model of language, the ability to translate from one language to another, but while taking into account the cultural specificity. You take this into account in WHO, don't you?
And I think it's something we need to do more of. But I know particularly there's been some thinking around large language models, of which chatbots are that chatbots use, and there's some specificities that may not be easily translatable, and particularly in areas of like reproductive health, talking about body parts, et cetera, and the way you communicate it, there's a lot of cultural nuances that vary beyond even just the direct language translation, which is something that we're trying to understand a little bit better, just understanding that in AI, the machine may not be able to readily understand those nuances, and there needs to be some work to be able to make those linkages. And there's been some great work happening in Kenya with Jacaranda Health and others, where they're really trying to go a little bit deeper into making these translations for languages such as Hausa, Swahili, Zulu, etc., where the direct translations may not be always appropriate, and you need to get to that additional level of contextualization, or what they call transliteration. Thank you.
Quelque part, vous me rassurez dans ce que vous dites, Tagguer, ça veut dire que l'humain a encore quelque chose à jouer dans cette histoire-là. D'autres questions, d'autres remarques? Messieurs, on vous apporte des micros.
Could you introduce yourselves when you ask a question, please?
Hear me? I'm speaking in English because my question was to Aparna.
Yeah.
I was definitely, through the discussions, I was thinking about the role of the mother-in-laws and how impactful they could be. At the end of your talk, you mentioned the question of the mother-in-laws, but I was rather thinking about the psychological mechanism behind the behavior of mother-in-laws. Are you assessing it? How could you explain, or how they explain themselves, like 20 years before or 30 years before, they were like suffering some of the problem issues we are pointing, and later on, becoming mother-in-law, they are actually acting against women, against wives. This is more or less for me the question. What is the rationale?
You'll be very surprised. I would like you to come to our field, really, I mean, what happens is women are voiceless. The mothers-in-law have really suffered a lot, as you said, and when you get their voice in, you ask them the questions, right? I mean, when we go into evaluation, we really actually talk to them also to understand in our preliminary research, and then even the evaluation later on to see how the program is working, their voice is taken in. And when that happens and they feel heard, there's a transformation. Secondly, it's a power dynamics at play, and that power dynamics is play not just because of they think that way. It is a gendered thing inbuilt in them from years of patriarchy, right? It's that whole patriarchy. You might think the women work against other women. It's not that way. It's just been so imbibed and enforced by society. And when you discuss that, and you have the nuanced content discussing that, if you look at the content, it marries tradition with small modern touches. So if you look at the mother-in-law character, it has got a lot of research has gone into developing the mother-in-law character, who is somebody who is modern yet in touch with her, traditional choices, but also recognizes that she needs to change with time. So hopefully by introjection, those behaviors, Yeah.
La question universelle de la belle.
This is a universal question about the mother-in-law in all the countries of the world. Another two questions in the room? Madam?
Thank you so much. My name is Nelly Munyasia from Kenya, and thank you to the presenters. My question, I don't know who this will go to. I worry, when we think about digitalization, I worry about adolescent girls and young women. We are already talking about mother-in-laws, they are not married. We are talking about language, and I know, for example, in Kenya and across Africa, we have a language called slang. I don't know if we have such across other countries. This is a language that has been broken down, that is both in Swahili and English, and thinking again about the health-seeking behaviors of adolescent girls and young women, and I talk this with a gender lens. They will be looking for this information in the middle of the night. How do we make this information digitally available for them? And also this information, appropriately available for them, and who is this that is providing, which is this digital platform that is available to take care of their needs. Also appreciating that they would not also maybe be in a position to afford even the bundles for them to either access a chatbot or a website or a WhatsApp platform where some of this information could be. Thank you.
Qu'est-ce qui peut répondre, Smisha, très rapidement, et ensuite on enchaînera sur la suite.
Very briefly, please.
Very complex question, very briefly. So, but I think the access to internet connectivity and digital data, even amongst adolescent girls, is actually rapidly increasing. But you're right, it's not equal in all parts, especially not in rural parts of most countries. In urban parts, there is high accessibility, and there is a rapidly changing. There's a rapidly changing way in which people access information. Where in the older generation, people still need to see a face-to-face doctor. The younger generation is much more comfortable with digital services. I think there was a survey conducted of young people that suggested that over 65% of them, and this was in 6 sub-Saharan African countries, that said that 65% of them access mobile health services. And so a lot more research actually is needed to understand how we can make that information accessible to young people. And then, as I've previously mentioned, ways of like chatbot and online services, there's need for privacy, but it's also offering a really good advantage because there is some level of secrecy, which face-to-face services don't often have. And there's reduction of stigma in an online environment, which again, the face-to-face services don't really have. So changing trend.
Merci à tous nos intervenants de cette première table ronde.
Thank you to all the speakers of this first panel. There's still a lot more questions, but we'll answer them later on. I'll let you go back to your seats. We have a very busy day ahead of us. We are going to continue now with another major subject, which is artificial intelligence.
Bouleversement majeur dans le monde, je vous le disais, avec le développement donc de...
Well, a major development in the world with the arrival of artificial intelligence with incredible possibilities. But the risks of errors are many as well. AI needs enormous databases. And in the field of health, there is a risk of bias if women are not numerous enough and the data not used correctly. Isabelle, a founder of DataCraft, is a club, a group of experts with 600 research scientists with many large companies. I give you the floor. Thank you very much. We have 42 companies now.
Oui, bonjour à tous. Quand on m'a demandé de réfléchir à ce sujet, des biais de genre qui existent dans les systèmes de...
Good morning to everyone. When I've been asked to talk about this gender bias, whether they're enhanced by artificial intelligence or not, I thought it was a great topic. Generative AI, they do happen in society, so they do happen in AI, or they are highlighted and accentuated in AI. Of course, you have to take that into account, but I wanted to talk to you about thinking about AI, whether it can help us to really be aware of this gender bias and try to eradicate them in a certain way and work on them anyhow. I think both approaches are interesting. To start with, I thought it was a topic that was highly interesting, that many people were talking and working on it, and I spoke to many friends in the health world, and how do you address this topic? And health medical centers, I thought, oh, your subject is really great, but, well, we know it's a topic, but we're not tackling it. We haven't questioned ourselves about AI solutions that we're starting to use very, very modestly in most healthcare centers, but we didn't think about it in that way. And if we did, about gender bias, they exist in healthcare centers, and how do we address them? So in the same way, I spoke to people who are in charge with everything that has to do with institutional regulatory systems for health systems. They gave the same answer. So the ones who were more advanced were a few researchers, a few doctors. I don't have the right representative sample, I'm not pretending that, but the ones who had questioned themselves about this topic were health professionals, researchers, where there are resiliences with symptoms, where there are differences between men and women, or cardiologists and other doctors, and their testimonies are interesting, and I have noted them, and I think it is very interesting. And I started thinking, what is a gender bias? I had my own idea, but I wanted a more scientific definition of it. Gender bias are cognitive bias that are due to unequal representation of men and women, which where information are really feeding a decision. We know that information are paramount to create algorithm. Of course, we understand there's a real issue here, and those prejudices preconceived ideas are unconscious, and they have been building a long time on the basis of education, of cultural environment, but also through lived experiences. And you need a real effort to really be aware of this gender bias and to accept them. Because you might think, I don't have any gender bias, but if you want to work upon it, you need to really make an effort. And why are we wondering about those questions today? Because, of course, it can contribute to a society model that will be more sustainable and fairer in its way, but also because you have potential effects that are unexpected. And for all those reasons, it is important to think about it. We were talking where the World Health Organization spoke earlier. Since the end of the 80s, the World Health Organization wrote a lot about this topic and displayed many theories. So you have those bias, gender bias in the health system at all levels, everything that has to do with prevention, and it is well documented. I was very surprised. I have found work dated back from 2022 about a cohort in a prevention center of cardiovascular diseases, and there's a real difference between men and women in cardiac diseases, and there was an underrepresentation of women in the cohort, and really it is something that is quite usual, even if we see that many efforts have been done since the end of the 90s to try to balance this those differences, but everything has to do with cohort. Well, the study group, and it applies to gender bias, but for all kind of bias, you can see that the representation of the group is not well balanced. And often the diagnostic phase, when you see in the interviews that are carried out, one can see on a regular basis that the interpretation of symptoms is influenced by those prejudices and by gender prejudices. Therefore, in many studies I have found, and within the exchanges I might have had with professionals, one can see that health professionals they were going to focus on the emotions that can be expressed by women, because it's more representative, and they will focus more on diagnostic, scientific diagnostic, and body examination of men, where it is linked to the gender bias that we have. What we know is that there are a few diseases that have that will express themselves very differently between men and women. And there again, it is not documented at all. So it is a very important gender bias in our healthcare system, cardiology, but everything is to do with urinary tract diseases. The treatment response is not the same at all. So it is paramount to take into account those gender bias from the onset. And in our traditional system, it is not the case. What would be interesting would be to know whether it's going to get worse with using the artificial intelligence system. Is it going to improve things or make them worse? In the World Health Organization report, there's prevention, diagnostic, but also there's a whole part also on taking care and treatments. With the care and treatments, in many studies, it's coming out of these World Health Organization report, but also in many other reports. You can see that in clinical trials, there's a real question about the presentation of men and prevention, even if it's more inclusive now, but there are more men in clinical studies. I'm going to read that to you. I have a few testimonies which I found really interesting to highlight that. This cardiologist was saying, We are caring better for people who look like us, people like us. And that was her report, and she was aware of that. She said that she takes better care of women's health when it's a woman who is caring. You can see that in many studies. There's in The Economist an article in April which was touching upon that issue, and she was saying that I find it more difficult, more easy to be show more empathy with patients I am identifying with women, because she was a woman, and she was questioning that, saying that maybe using artificial intelligence solutions, this empathic bias, to be a woman or woman or men, maybe it's going to help to reduce this gender bias. Of course, that's a reflection we have. The artificial intelligence doesn't have a sex or not. It was conceived, designed by human beings, so maybe it has its own bias too, and more empathy for certain patients. That is another question. But I thought it was very interesting to have this questioning. Then also now we're talking about this topic of gender bias in the healthcare system. The question now is what is different? The artificial intelligence. What is the intake, and what are the changes coming from artificial intelligence? The first thing that came to my mind a few years ago, I don't know if you remember, in 2017, the NHS, the healthcare system in Great Britain, worked with a startup that was called Babylon Health, and they designed an application that allowed English citizens to have the first advice, kind of diagnostic, according to the symptoms they were describing. It was an advice saying maybe it's an emergency, you should go and see a doctor, etc., the GP. So it was based on artificial intelligence that was proposing answers according to the symptoms. And there was a big scandal because it was tested by a woman. She was in her 60s and she was smoking, and she described symptoms of being oppressed and being breathless. And the application said, so it was either that she was depressed or she was in anxiety and panic attack. And a man had the same symptoms exactly, with the same medical record, and he was told it was probably a cardiac problem, and he was orientated differently. And they stopped using this application, and it questioned the whole use of artificial intelligence, saying it was not reliable, without thinking that maybe a human GP might have had the same gender bias. Maybe it is a topic for me, and I feel really I trust. It gives me trust, because when you use AI, contrary to when you have a GP, you talk, you're a human being, you trust, but you do trust the GP or the doctor. When you use a artificial intelligence solution for such very important decisions such as health, you don't really trust the system. We work always very regularly on AI projects, and we don't trust really what is the trust. Maybe he was fed with the wrong data, and what is going to come out of it is not going to be reliable. As we always say, when garbage in, garbage out, well, that is it. You don't get the right data. So this lack of trust in technical solutions and in AI, it's actually something that is a chance that we have to grasp. It's something, an opportunity, I would say. Often we go and see a GP and we want our second, third advice, but we We don't think about his educational system. Did he or she learn the right things? We wonder whether he or she is competent. But when you don't question everything. When you use an AI solution, you question many, many things, and you try to have something perfect. But you wonder about things that, for example, you wonder about the bias of a health professional. With AI, you do wonder. You do ask questions, and therefore, it is a question and a factor of hope to have solutions from the AI. Another point is UNESCO report I was quoting. I think it is very interesting. Look at it if you can. It's called Challenging Systematic Prejudices and Investigation into Bias Against Women and Girls in large negative models. So it is a recent report, and the UNESCO team, it was the department that was working on new technologies and artificial intelligence, tested many solutions for a large engagement model to see whether they have biased. It wasn't not just for health, just to see what were gender bias in models. So they've GP2, GP2, and Meta. Of course, every day we have new models coming out. So, of course, there's an improvement and attention that is given to those topics. But for Amadeus, what was important is that 20% of the content that was generated, that was sexist and misogynic. So, really, you think if that is used, if it is customized to make recommendations about health, it is worrying. In the exchanges that we had earlier in the roundtable, there is this thinking, reflection about whether it is intentional or not to feed information that involuntarily are creating models that have sexist biases. That's a real topic. And this very recent analysis shows that, yes, it can happen, and we can question it. I think what is important to look at, and in this UNESCO report, they chose to look at the data collection issue that is really a topic. I wanted to time my speech, but it didn't work. Well, as I was saying, what is important in this report is that there's a real focus on data, because one knows that often the AI bias is linked to the data that rehearse the model, so they are biased themselves. And if they are not corrected, they're going to stay in the loop, and it's going to highlight those biases. It depends how the model is built. So what I was saying in my introductory remarks, we don't have that many data that are tagged and associated to a real sex, whether it's a woman or a man. When you have the tag to be able to differentiate whether it's a man or woman, well, we don't have that many. So you can't question yourself about this gender bias. It wasn't really thought as a huge issue in certain study group. There is not such a big representation of women. Well, then we think that the data are not good quality data to really launch the model. So we have been highlighted a lot, the personalized medicine. It's very important. But when you think about personalized medicine, you think about giving the right treatment to each individual. But it wasn't well addressed under the gender angle. It was personalized, but the way it is conceived, we don't say we start collecting data specifically for men or women, or for women, to be able to personalize medicine. So therefore, if we want to do that, if we want to launch algorithms, you will need to collect data that are tagged and the right data. The second topic, once you have selected data, is selecting the right algorithm. And there you have algorithm libraries that are available. You have lots of open source algorithms that are open sourced, that are available. Some are you have to pay a fee. Others are developed by organizations. But one can see that there are many algorithms that were launched with a bias. Not in health, but a few years ago, Amazon used an algorithm to recruit, and the algorithm was rehearsed on population of Amazon teams. Decide that the best profile to be data scientist or on text messages were men, because it was only men who were represented in the personnel. It wasn't intentional at the time, but it did recreate a bias of the situation, and then another bias said that best GPs will be women, because now there are many women working as GPs. So it'd be a total gender bias to say that if data were not corrected. Also, you have deployment bias. What I mean is that once you have rehearsed an algorithm on within a certain context, if you change the context and you didn't take into account the specificities of the gender bias, when you use it within another context, it's not going to work. And you can have things that are completely wrong, mistakes that are generated by the AI. Maybe, how long? 1 minute. Okay, I'm going to be quicker. I can give you a list of good practices, and maybe I'll give you a few testimonies later. But for good practices, when you implement an AI project, what is important is to have a very inclusive team from the onset, not necessarily experts. Inclusive means with non-experts of artificial intelligence, inclusion of the trade, the business, but also we have Asperger, autism, boys, girls, and men and women who are working on this AI, and they have a different outlook on things. And in another way, you can have more women, and you can have AI solutions, and women can develop that. Governments too. It's very important. It was designed to use data in a way that is not the one done with AI. It is important to think about governments, in organization, the fact that we include everyone. We think that all stakeholders, all actors have the right understanding of this topic. What can we do and cannot do with AI? I think it's very important to use the AI correctly within their organization. In France, trade unions are now thinking about that, to saying that we're going to give tools to workers' representatives so that they have the right analysis. So in the health system, it is the same. We need to have all stakeholders that are associated to that. Well, I don't have much time. 20 seconds. Okay, so one testimony. I shall finish with that. I think it was a urologist, and he said the strength of ChatGPT. He was talking about generative AI. He was talking about hypothesis generation, and gives many hypotheses. I have a patient who's had he came for all his abdominal pain, and ChatGPT gave me many ideas of diagnostic, more or less serious. And then he thought maybe I have too many tests. But and then when you don't have the expertise, it is quite reassuring. And this patient had an abdominal transplant. And therefore, the partner can be interesting. This AI can help. And as a conclusion, what I'm thinking is that we need to be heard in health matters. It's really important. When you look at AI solutions, when you do that, they're quite empathetic and they answer quite well, and people feel they have been listened to. So you think that's great. But when you carry a second study, you realize that even if there are all these positive points, people have a feeling of they've been listened to in a much better way when they speak to a human being. So it is a tool that allows to make things more reliable. It is a first listening, first reading, but then you need to have the human listening, the human contact. That is paramount. Thank you very much, Isabel. Thanks for reminding us that we're human above everything. So we are going to go to the award ceremony now for the ODESS 2024 key awards.
Et premier lauréat cette année, il nous mène aux Philippines. C'est Atipan Plus, un programme qui permet aux populations les plus éloignées de systèmes de soins de bénéficier de téléconsultations via smartphone ou tablette. Et grâce et surtout, entre autres, à l'implication de coordinateurs de soins directement issus des communautés. Et on le découvre en images.
Our project is called Atipan Plus. Atipan is a native word. It means to take care of. The project is actually a telehealth program to remote, indigenous, and rural low-income communities in the central part of the Philippines called the Western Visayas region. Their communities are very small communities that are subsistence communities, so they occur very far from the cities, and they're very poor and marginalized. So in those places where they dwell, there are no healthcare facilities, and it takes a while to get to their community sometimes. So we established this telehealth program so that they can do their healthcare within the locality. Healthcare is very easy to access now, and they don't have to travel long distances to get healthcare. I think our community healthcare coordinators were almost the heart of our telehealth program, because they were community leaders, and then they were the ones leading the facilitation of the telehealth. So I think maybe this is the reason also it became very successful, because we already had somebody who was highly trained and who was trusted by the community. By around the end of our first funding, we attained a very high number of telehealth consultations, and I think this was mainly due to the healthcare coordinators.
Voilà, Atipan Plus.
Atipan Plus, Pierre, Regina, Fatima, Zamora.
En même temps, voilà, Pierre, toute première question.
First question. What is it like to have come from the Philippines all the way from there. Now, what is it like to? Can you hear? Can you hear? Yes. Can you hear? Can you hear the translation? Yeah. Okay. Pierre. For us, the Philippines is the other end of the planet. So, what is it like for you to have come to Lavore, Toulouse, Pierre Fabre to receive this prize? What is it like for you?
Most, it's validating both for the Center for Informatics and at the same time also our partner communities. It gives us the idea that we are in the right direction in terms of digital health and who to give access to.
Une des clés du succès
One of the keys of the success of this project is based on health coordinators who come directly from the communities. Why did you make that choice, and how do you choose and train these coordinators?
So we wanted to work with the communities. So for the telehealth setup to be able to work and to be able to be implemented well, we needed health coordinators from the community. So they know the language, they know the social, cultural barriers, and they are chosen by the leaders of their community. Not only the leaders, some of these communities, they have the community resolution. At the same time, they do hold meetings, and they are the ones who chose them. We have our own criteria, but it's just a guide for the community leaders who to choose. Like, for example, those who can understand Hiligaynon. So that's our dialect, as most of our doctors actually speak Hiligaynon. They have to, at the very least, know how to speak Tagalog. And English is not a required language, so either of the two.
Et le reste de la question, effectivement, c'est comment...
And the rest of the question is, how do you train these coordinators in your center?
So we actually bring them, all of them, because it's a lot easier and cheaper, to bring them all to the city where the center is located. So they are trained in health data ethics, as they will also be a part of the team who will be seeing a little bit of the health data. At the same time, also training on how to use the ONIEMR Tele, so that's our database platform, and also the use of the gadgets. And other than that, although we have IP, Indigenous Peoples communities, we also have rural low-income communities. So in those areas, we also do cultural sensitivity. And alongside the training for health coordinators, we also have the training for the doctors.
Toute dernière question, Pierre-Regina, est-ce que vous avez...
Last question. Have you been able to measure the impact of your program on the health of those communities that you serve?
So this is, like, we only touched the tip of the iceberg, honestly. It's only been 2 years. But first, we have been able to provide healthcare access together with the communities. So it didn't actually start as a co-maker setup, but it did along the way because we wanted to engage them. Because in order to be sustainable, the communities need to be they need to be a part of it. And then at the same time, so that's one. And then, sorry, can you please repeat?
Non, la question était celle...
I was asking you, what is the impact on the health of the inhabitants?
So, one, again, the communities were able to provide healthcare access. So as shown in the video, there were, at the end of 2023, so that was the end of the 2-year project of the first funding that we got, there were about 7,000 plus beneficiaries. So those beneficiaries are from the partner communities themselves. Also, some of the communities that were not originally partner communities but actually heard that at the Atipan services are being made available in our partner communities, they actually go to the healthcare coordinator. So we actually did not, the services weren't contained in the partner communities, but all the other underserved areas in the region actually were able to benefit. So this just gives us an idea of how much more we can do in this setup. And then other than that, although we haven't really did a formal a formal study on this, but we did get testimonies. So especially for indigenous people. So the indigenous peoples community, particularly for the Ati, they are usually being discriminated. So they're quote unquote, they are dirty, we don't want to be seen by the doctor because they might say this and that. So that actually adds to them not being able to access healthcare, even though healthcare services, some healthcare services are near their community. Sometimes they do not want to go there because of such discrimination. So with telehealth, they are able to consult with a doctor and at the same time also be able to do it in a rather comfortable manner within their community. So I believe that's the three. So that's first, that's healthcare access. Lastly, the data. So in the last 2 years, we had the data already. We have the top 15 conditions, the medications, so we can use that for resource planning.
Et on voit, comme avec vous, les questions de data, de sociologie.
Data, sociology, evolution of society through technology, all this is linked together. Thank you for this project. Dr. Bunchide is going to give this prize. Please come up. Dr. Buchai, you're a pillar, a long-time partner. Why is this partnership important for you?
The partnership with the foundation, right?
Yes.
Yeah, I think this project is a very good example of the mission of the foundation that would like to get people who are not have opportunity to get the healthcare, to be able to do that. And these projects, I think this project is demonstrate that we can use the digital technology to implement the way that we can equalize the opportunity to access the healthcare. This project implement in the indigenous people citizen, which has a very less opportunity to do that. So to me, I think this project is had been demonstrated both sides. One side is the mission of the foundation and also our network that would like to use the technology, the digital health technology, to benefit the health system and healthcare. So it is like Dr. Pierre said, you can see that, like you summarize, it's not just the technology, it's sociology and the people and also the good heart of the doctor in that community that would like to reach out to the opportunity people to get more healthcare services. So, and she said, this is just the tip of the iceberg, which means that they work very well with the people, the provider, and the people working very closely. That's why the middle people, like the coordinator, is very important, and they use the strategy that to get the people in that community. I already talking with Dr. Pierre about how you choose them. but the way that they go to interview and then come up with the consensus. And this is, I think, the perfect for the for you to get this kind of the award.
Merci. Bon, je vais vous laisser remettre ce prix. Venez.
I'll let you give this prize. Please come to the front so that we can take photographs with the whole team. A round of applause for this prize. Atipan Plus, a project developed for remote communities in the Philippines. Thank you very much. Please stay with us. I propose we go to Thailand now for the second prize winner. Estrat is the name of the project. Health in 3 hospitals using blockchain technology to guarantee the confidentiality of patient data. Digitalize healthcare data via blockchain.
Technology to create a secure patient control personal health record system in Thailand. A Web3 healthcare infrastructure that integrates all stakeholders in the healthcare ecosystem, including hospital, healthcare providers, patients, and healthcare technology platforms into a single platform. This system enables seamless and secure sharing of healthcare information with high levels of privacy, trust, and transparency, putting patients at the center and ensuring interoperability across the ecosystem. And this innovation solution addresses the fragmented nature of healthcare data, not only in Thailand, but globally. Health tech has a significant impact on the healthcare landscape by empowering patients, streamlining workflows for providers, and fostering a data-driven ecosystem. Patients benefit from secure control over their health data, enabling informed decisions and improved care coordination. Healthcare providers gain access to comprehensive patient records, facilitating accurate diagnosis, efficient treatments, and reduce administrative burdens. Ultimately, health tech contributes to a more connected and effective healthcare system, supporting the future of healthcare and improving health outcomes for all.
Voilà, le projet Elstag. Pour recevoir ce prix, on accueille le docteur Deshowat Promda qui est venu de Thaïlande.
Promda from Thailand, welcome. You already have a mic, so congratulations. I have a question. Now we understand how important blockchain is to guarantee the confidentiality of patients' records. But is the patient sensitive to that? Is it important for the patient?
You want me to ask you again?
Yeah.
Yes, I was just asking you. That may seem stupid for you, but does that has any effect, this blockchain, about the patient? Does he really care about that when he goes to the hospital?
Oh yeah, that's right. Actually, patient doesn't care about the technology. What we build is we try to make this kind of deep technology access to our patient, even though they are ages or they can use smartphone by creating just one tag that can connect with the blockchain network. Yes, we just use the blockchain technology to create a secure and interoperable healthcare systems. That's why we choose this technology, because it's highly secure, and also we can control the privacy inside of the smart contract. Yes, but patient doesn't have to know the technology behind. Yes.
Mais vous indiquez, ça c'est très important, que le patient peut avoir accès.
You said that the patient can have access to this data. What can the patient do with this data that he has access to? Did you hear, sir? No.
I can ask you, you said in that video that each patient can have any access to the data. What could I do concretely with those data, for instance? And do patients really use this opportunity to have this access to the data?
Yes. Actually, right now we only pilot for the medical data. So patient have they can control their access to the data from the different hospital, and also can give the white list to the healthcare provider to access their medical records with their own consent.
Okay.
Yeah.
Et toute dernière question, cette fois-ci du point de vue hôpital.
Last question, from the point of view of a hospital, what is the advantage for a hospital, as it is a competitive advantage relative to other hospitals?
As a physician, I experience firsthand the challenges caused by fragmented healthcare data, and that is why I create this kind of technology to reduce the problem, to enhance more efficiency of healthcare providers, and also reduce the problem from the fragmented data. That is the benefits from the hospital. Yes.
Ouais, d'avoir un bénéfice pour les soignants. Je peux oublier, ce sont eux qui sont aussi au cœur du...
I had forgotten that caregivers are the heart of the system. Nicolas Menetti, Regional Director for Asia and the Pacific, the university agency which is a long-standing partner of the e-health observatory. Nicolas Manetti, what is your opinion about this project? The mic. Congratulations for this project. As you recalled, I work in Asia and the Pacific for e-health, and this is a good testimony of the high innovative capacity of this region. So this is encouraging. Why did you come today here to award this prize? The University Agency of Francophonie is the first university network in the world with more than 1,000 member universities, and we are a regular collaborator of the Pierre Fabre Foundation in Southeast Asia with various networks, and we also various programs, and we also have networks of pharmacists and physicians. So we are highly directly concerned by this theme. And we are going to have our International Assembly next week. Thank you, Nicolas Magnetti. Please come to the center of the room so that you can award this prize and we'll take a photograph.
Voilà, on va faire une belle remise de prix, une belle photo.
Right, beautiful photograph for this prize award. Thank you very much. We come into the end of the morning. I presume you have some questions to ask our prize winners. Do you have any question? Yes? Good morning. A question for Elstag. What are the means you have to authentify the patients? Authentication means. We are going to repeat the translation.
It identifies the patients. I don't know which technology do you use or what kind of applications.
To identification.
Yes.
For the patient. Right now we use just the KYC technology to identify the patients in front of right they are arrived within the hospital. Yes. Not okay.
No, just speak in your microphone. That's because of the translation.
Okay. Yes. Just normal KYC. Yes, to identify the people right in front of when they arrive in the hospital. Yes.
D'autres questions, d'autres remarques dans la salle?
More questions or more comments in the room? None? Okay. Yes, madam there. Good morning. I'd like to congratulate you and ask you a question on the teleconsultation program. I understand that there is a dialogue with health professionals. What are the clinical elements that you can take, like taking your blood pressure, listen to the heart? Do you have the necessary devices to do that? On the other hand, beyond consultation, what is the organization of the patient's management for access to medicines, for example, and for the durability of your program, the sustainability of your program?
Great, thank you. So we start off with the healthcare coordinator. So as I said earlier, we already have the gadgets, the phones, the tablets, but at the same time, they also act as the ones who take the vital signs at the very least. So you have your heart rate, blood pressure, respiratory rate, your pulse oximetry. So they do all that. They are also trained to do that. And then at the same time, during the teleconsultation, they also man the tablets and the phones. So they also know how to work on the database platform. And right after the teleconsult, we have actually medications and a little bit of funding, if we have, for direct dispensing to patients. And at the same time, we also have funding should there be like CBC, complete blood count, your general chemistry, blood chemistry. So we can do all that. Now, of course, we cannot do, we don't have the funding for that part of the teleconsult. So we also link up with some of the local government units. So there are local government units who we actually have a memorandum of understanding or agreement wherein with the teleconsult details, we provide them. The patients can actually go directly to them and get the medicine. At the same time, there's also another local government unit wherein there is funding available really for the entire jurisdiction of that unit, wherein the teleconsult patients can also avail of that one. At the same time, now for the sustainability of the project, so one really is the continuity of care. So telehealth cannot do everything. So at the very least, what we can do is have the most basic medications and then the most basic blood test available. At the same time, also maybe address conditions at the very start of the spectrum, not the ones that are on the worst part of the spectrum. So those, the acute cases that need emergency care, we immediately refer them to the nearest emergency room or the nearest hospital. So that is, I think that's the next part of our work, is to establish that continuity of care, the referral network that these patients need to be actually integrated in the first place for them to, you know, just complete the entire thing.
Question au fond de la salle, Caroline.
A question at the back of the room. For Kia. This question is asked from Vincennes. When you developed the solution, how did you take into account the specificities of ethnic minorities? Did you take a social approach as well in order to understand them better?
On demandait lorsque...
When you developed the solution, how did you take into account ethnic specificities, the specificities of ethnic minorities? Did you adopt a social approach in order to understand better how they operate and their culture?
So if I understand it right, so there are specificities socially within the community. So, okay, in terms of accessing healthcare for these communities, what we noted most was most women actually go to consultation together with their children or sisters, grandmothers, mothers, aunts. So they would usually, their conditions, especially if it's benign, actually get addressed when they actually bring someone along. So they don't really go directly even to a teleconsult with a benign condition. So only if it's truly painful or if it's really, they're really afraid of what the outcome might be, that's the time when they go to a consult. So that's for the women. For the men, they work during the day. And most of the time, actually, they are the ones who actually have the conditions that are in the worst spectrum already when they come to us because, like I said, they had to work. So a particular case would be an infected wound. So it went on for like 2 weeks, and that's when he started to consult. But by that time, a teleconsult is not enough. It needed to be cleaned already at the emergency room. But he still didn't want to go to an emergency care. So after a thorough advice, we gave him an antibiotic. But at the same time, we said, if it does not, if things don't go well in like 3 days, you have no choice. You have to go. So that's one of, like, in terms of accessing healthcare. Another would be the Ati community. They have their own cultural setup. For example, they have their own beliefs. So they usually come to us when they have exhausted all those beliefs already. And that's okay with us, actually. So.
Toute dernière question de Madame.
One last question, Madame.
So my question is for health tech, and if I understood correctly, health tech using blockchain technology and FHIR standard, you make the health data available to the patients, the health data that is from the electronic health records of these 3 hospitals, right? And what kind of health data is it? And then did you face any kind of constraints in terms of the legal regulation about what kind of data could be shared or not? Did you have to have like approval from the government? And also, did you face any kind of restraints, resistance from the physicians, for example? Sometimes they don't want to health data available to the patients, right? It's in a way, it could be like a monitoring quality evaluation. So did you face that kind of, any kind of restraints or constraints?
Yes. First of all, for the regulation part, yes, we face a lot of problems that have to be solved from the regulation part, such as the GDPR or PDPA, the privacy regulation in Thailand. Yes, we have to work with the government and let them approve our system and also our technology for using to manage the privacy of sensitivity of healthcare data of the patients. And yes, we got some resistance from the providers as well, from the different hospital, especially in the private sector. They don't want to share the records. That's like in the public hospital. That is why we start in the university hospital and start in one of the biggest hospital network in biggest medical school and oldest medical school network in Thailand called Siriraj Hospital. They have 3 different hospitals, but in the same network. So that is why they wanted to share the record across the border. But in the private sector, we still got a lot of resistance from sharing the record, because they don't need to they don't need everyone to see the electronic records. Yes.
Merci docteur pour ces précisions. On peut applaudir une fois de plus nos deux premiers lauréats de...
Thank you very much. Now we are coming to the end of the first part of this award-winning ceremony. Thank you for all those of you from all over the world who've been listening to us. We'll have a break now, and we will carry on this afternoon to talk about the digital systems as empowerment enablers. For those of you who are on LinkedIn, you'll have to reconnect this afternoon, because we'll have a new live this afternoon. You'll have to reconnect. And for those of you in this room, if you have taken a headset for the translation, do not forget to leave it behind, to leave it here on the table before you go. And we'll meet again at 14:15 Paris time. See you later. the definition of the problems and
I can't hear you. Yeah, can you hear me? Can you hear me? I think probably not.
Okay. Can you hear me now?
Yeah, I can hear you now. Could you hear me?
Okay. Yeah. Okay. Thank you. Sorry, it's my Bluetooth headphone.
Yeah.
Okay. I think it will be very easy because I can hear you and see you very well. So if you are in the same configuration in 1 hour or two, I don't know, but if you are in the same configuration, it will be perfect.
Okay, so I dialed on earlier and I could hear the English and like the French. So I will just listen to the translator and then I speak in English, obviously, right?
Yeah, exactly. It's very important that you need to select English interpretation so that we can hear you in English too. But
I
that's
see.
yeah, and you unmute original audio. That's what they say in English. Okay, but it's perfect if you use this kind of video card, etc. It's well, you look great like this, so it's perfect.
Great. So that's it.
That's it. We don't need more tests from you. It's just to check your internet connection, etc. But as you are on with your own computer, with your own equipment, etc. Earlier we tried to talk with the Laos, but they was in the big school room, etc. And we can't hear them. For you, it's very easy. So that's it.
Great. So I will come online maybe 10 minutes before.
10 minutes before the round table. Yeah.
Yeah.
Okay.
Great. Okay. Thank you very much.
And just yeah, but you open your chat. I will be with the chat. So if there is any problem or if there is any I don't know delay or something like this, I will write you.
Okay. I have another meeting at like on the hour, so I can only stay from like 8:15 my time. I think it's 4:15 to 5 o'clock.
Okay.
Is that okay?
Yeah. And if it's late for you after this, I think you will have the time to talk because we start with your we say your panel, but yeah, I'm confident you should be able to be on time.
Okay, great. So I'll join again in about 1 hour.
Okay, thank you very much.
Okay, thank you. Merci. Bye.
désormais, ils sont diplômés, mais la loi togolaise ne prévoit pas cette partie.
bonjour à tous donc, et bienvenue dans cette 8e édition de la conférence annuelle de l'Observatoire de la e-santé dans les pays du Sud. Seconde partie, toujours consacrée cette année aux iniquités de genre, toujours en direct de la Fondation Pierre Fabre à Lavore, près de Toulouse, en France, et retransmis en direct sur les réseaux sociaux partout dans le monde, en français comme en anglais. Pour information, sachez que plus de 500 personnes nous suivaient ce matin en direct pour cette conférence, avec des campus qui étaient ouverts en plus un peu partout, en Égypte, au Cameroun, en Côte d'Ivoire, à Madagascar, à Bordeaux, au Laos, en Thaïlande, mais aussi à Lomé, où nous dirons tout à l'heure au Togo. Merci à vous tous qui nous regardez vraiment en direct sur les réseaux sociaux. N'hésitez pas toujours à envoyer vos questions, envoyer un petit coucou. On en a eu pas mal ce matin, et chaque fois qu'on reçoit un petit message, je trouve que c'est un rayon de soleil qui arrive depuis les pays du Sud dans cet hiver du Nord, et le Sud, eh bien, on y replonge de plein pied pour poursuivre tout de suite nos réflexions sur l'usage des outils digitaux pour réduire les iniquités de genre. Comment est-ce que le digital peut être un levier, alors on disait d'empowerment pour faire de l'anglicisme, d'empouvoirment, dit-on aujourd'hui officiellement, ou en pouvoir d'agir, voilà, en français. Comment est-ce que le digital peut aider en la matière? Comment ces outils peuvent-ils embarquer des communautés, donner plus d'autonomie, de pouvoir aux femmes? Eh bien, pour y répondre, vont me rejoindre tout de suite Nelly Munyasia, qui est directrice exécutive du Reproductive Health Network Kenya, le réseau de santé reproductive au Kenya. Nelly, hop, voilà, venez me rejoindre ici, on peut l'applaudir. Elle qui vient du Kenya pour participer à cette conférence aujourd'hui. Assiatou Niang de l'ONG Speak Up Africa au Sénégal, voilà, qu'on peut applaudir également. C'est une ONG qui prend la parole. On verra avec vous sur des grands thèmes de société. Vous créez des liens entre les acteurs politiques, associatifs ou autres. Et vous allez nous parler d'ici quelques minutes de votre tout nouveau programme de mentorat, notamment pour les femmes africaines dans le domaine de la santé numérique. Nusura Myonga, voilà, va nous rejoindre également. Vous venez aussi de loin, puisque vous avez fait le déplacement de la Tanzanie. Vous êtes chef de projet dans l'ONG Her Initiative. C'est une ONG qui est montée par des femmes au service des femmes et des jeunes filles pour leur donner plus d'autonomie avec le soutien, entre autres, des outils digitaux. Et puis enfin, en duplex.
To give them more autonomy. And then in duplex with Assiatou, Alexandra, Tyers-Chowdhury, you've been working, Tyers-Chowdhury, been working for a very long time in Bangladesh, you're an expert on sex equality and digital gap at UNICEF. So Nelly, so we have these NGOs coming from Africa, Nelly, Munyasia, Alexandra, Tyers-Chowdhury, Duplex, Assiatou, Niang, and Nusura, Myonga. So if you should be able to make your own choices in terms of reproduction in social environment that is quite poor or rural. So before you use digital tools, before telling us why you should do so, why is it so important for you to give information? It's important to give information. Why is it so important to inform people in Kenya?
Part.
Yes, I'll summarize again. Very simply, we insist a lot on information of young ladies and women in general since this morning. Why, for you in Kenya, is it so important, this challenge of information?
And really excited to be part of this very, very rich conversation, especially around digital health. I work for an organization that works to reduce sexual reproductive maternal morbidities and mortalities, and more importantly, among adolescent girls and young women. And why is information important? For the longest time, access to information has been a greatest problem because of social media
myths and misconceptions where ordinarily adolescent girls and young women are not allowed to access information around sexual health. And this is because the men have the power and they believe that, for example, if a woman is to get married, a young girl is to get married, then this means that it's the man that should be providing this information. A lot of this information has also been there's a whole issue around this information being from the North and being a white agenda, and therefore not being contextualized to our context, where we see young girls getting pregnant at a very early age because they do not have the information in terms of where to access services, for example, contraceptives if they need, if they're pregnant, where to access safe motherhood services. And then also the issue around disinformation, a lot of disinformation in this era of digital platforms. There is where, for example, manufacturers want to market their products, so therefore they'll be giving the wrong information or information only limited to the benefits of their products, which might not be very important. And the whole issue also around opposition. I don't know if in countries where you come from, in the Global South, we are experiencing a lot of anti-gender groups that, are trying to impose on us what they're calling family value-based approaches to SRHR, where they're forcing, they are preaching the gospel of abstinence, and that is something that doesn't happen in Africa. Poverty indicators are very high. Young girls find themselves getting married because they're coming from homes that are young, child-headed, or they're living with grandmothers who are bedridden and they're not able to afford $1 a day. At the end of the day, they end up engaging in transactional sex, and so really abstinence then becomes a problem because they have to engage in whatever business for them to earn a living. I'll stop there.
On va voir d'ailleurs quelques images du Kenya. C'est toujours important de se projeter.
We're going to see some images from Kenya. It's very important to see. You can see that in this NGO for training. We have lots of taboo issues and topics within the women's community. Can you tell us taboo subjects and stigma that there can be around those subjects too?
And that video particular is a documentary that we did recently of a facility that we opened in one of the very, very rural areas and hard to reach areas. And this is a pastoralist community who majorly their role is to take care of their cows. And this community, young girls as young as the age of 9, 10, 11, 12 are forced into what we call female genital cutting. And this is some sort of transitioning from childhood to adulthood. So what are we saying? We see a lot of child marriage. And this is also because of the social norms. Then they get married at 12, 13 years old. And then the husband continues to get more wives, because again, traditionally a woman is supposed to be used to earn the homestead cows. So when you're married off at the age of 12, 13, then you're exchanged you're exchanged for cows. And we also see, of course, polygamy becoming a norm where it is allowed, and we see young girls becoming, you're young, but you have several co-wives. And this also predisposes them to HIV because, again, young girls do not have, or the adolescent girls and young women do not have the power or the agency to negotiate for safe sex. What does this transmit to? To an increase in HIV transmission. And all this is connected to the social norms around the community, our culture where men still have the power, where young girls are sold off so that the boy can be taken to school and given, education, because then they're considered as, they're considered as being very powerful and being the heads of the home. Then that means that every positive thing then has to be attributed to them.
Ouais, et pour compléter ce que vous disiez, notamment au niveau de
And to complete what you were saying about the need to inform, we often forget it is a taboo subject, but Africa is really the continent where the epidemic is propagating, and the first victims are often women. It's women who are victims of HIV. So we could see in the images you are doing lots of viral videos of information about sexuality, but also to fight against disinformation. What kind of video are you have you produced? For what kind of false information that was broadcasted on the social networks?
We use various forms of addressing the myths and misconception that comes with this information. And we have a huge following on Facebook. If you've clicked Reproductive Health Network Kenya or Nena na Binti Hotline, which is our call center, we have a huge following. And we use that because, one, when I say that access to contraceptives, for example, is considered a Northern agenda and not an African agenda. And so we want to show, rather provide information that population issue, demographic issue continue to be a very important conversation in Africa, and contraceptive is the only, approach or the only way that we are going to improve even our poverty indicators in our country. We also use Instagram, where we are targeting adolescent girls and young women. Like I mentioned earlier on, health-seeking behaviors of adolescent girls is quite different. They do not want to walk into facilities where they'll meet their aunts or people age mates of their parents, and therefore we are very intentional in using social media platforms where young people are comfortable at the middle of the night, where they would wake up and find the right information when it comes to sexual reproductive health. And also we are currently using TikTok, and TikTok is a big thing in the global south. We are seeing influencers that are young people, and what we've done as an organization is also build the capacity of those young influencers so that whatever content they're putting on their TikTok medias, then it's information that is very, it is useful information and helpful information to the young people. Then finally, we also run a call center called Nena na Binti, loosely translated, speak to an aunt. An aunt is a very important person in the global south. And therefore, we have a trained nurse counselor for about 5-6 of them, who manage the call center, and they provide right information, provide a safe space where young people can call in, speak to a counselor, and also provide information. And Kenya was able to be among the leading countries that domesticated the WHO 2019 reproductive health guidelines last year. And it is very broad. It is allowed for telehealth, has allowed for self-managed abortion. I know in Kenya, abortion is a bit restricted, but it gives the power to the healthcare providers. And so there is the grounds that have been broadened to allow for self-managed abortion, self-injection, HIV self-testing, and this allows for autonomy and choice. And we are using our call center that is also attached to a digital platform to provide information and refer to healthcare providers. Finally, in all this, we are centering healthcare providers at the center of all this conversation because they remain very critical and important element of the ecosystem. In case of any complications, then the healthcare provider, nurse, midwife, doctor, gynecologist remain very critical to ensure that they provide the relevant information and service. Thank you.
Passionnant parce que vous nous dites d'abord énormément de choses qui viennent du terrain, de votre expérience.
Yes, you're telling us a very important thing from the field, from the terrain. You are really, you have platforms that exist. You don't need to exist new tools. That very important platforms that are there, and you use them fully. Facebook, Instagram, TikTok. Lots of videos also that are on the WhatsApp. You have your own platform. You complete with a call center. You can see the digital strategy is really strong and massive, so that you can really have an effect on young populations. Throughout those social networks, do you see movements for changing the communities? When you send a message, well, through Instagram, let's say, or TikTok, you don't just touch one person. Touch one person, you can spread it around and share it with his or her circle of friends and family. So does it make mentalities and mindsets, do they evolve quickly then?
Of course, advocacy is not something you expect results tomorrow, but we are seeing a lot of, change in social norms. We are seeing a lot of change in attitude. We are seeing young people becoming more bolder and even asking for these services. And because what we do using our social media platforms and our digital platforms is, for example, provide information in terms of the legal framework when it comes to something like abortion, which is, usually very problematic, and just trying to let them understand what does the law of Kenya do, and therefore they are able to hold the government accountable and tell them, we know very well our constitution says this and we are demanding for these services. For healthcare providers, then we also see the attitude change, and we see in terms of how they even provide services to adolescent girls and young women in their diversities. And I insist on in their diversities because we have the trans population, people that identify themselves otherwise, that are also in need of these services. And a lot of times, these are conversations, again, in the Global South that are not being allowed. However, as a healthcare provider, then you need to know that your role is to provide services without judging. So using our social media platform, we see the change in attitude of healthcare providers, and also just getting the communities, creating an enabling environment for the young people that are in need of these services to access the services, and also the providers that are providing these services to be bold enough to provide these services. So we see the change.
Et on voit quelle est la force, la puissance de ces médias pour amener.
And one can see the power of those media to bring new ideas in communities, and communities are changing and a lot quicker. Just a last question, because you have lots of feedback from the field, from thousands of people. What are the topics, the questions that are more frequently asked on your different platforms?
Number one, is abortion legal in Kenya? And I think that one, if you went to any of our social media platform, you'll see that. And then number two, of course, the myths and misconceptions they keep on hearing when it comes to contraceptives, those are the most frequently asked questions. And you'll hear men saying, will my wife become, or will my partner be able to get children if they used contraceptives? And this is because of the myths and misconceptions that they get to hear. Then also the issue around sexuality education, they ask, aren't we sexualizing the young, the young children? So we are able to provide the right information when it comes to that. Yeah.
On voit avec vous l'importance.
One can see the importance of this digital strategy that is really well targeted, well identified, and they use this massively social network. And this morning we heard the importance to adapt messages to the people you had in front of you. And this is what you are working on, Alexandra Tyers-Chowdhury. You're with us live from Malaysia. So, of course, I'm going to ask you, what weather do you have there in Malaysia today? Huh.
Very hot, although it's a very big thunderstorm at the
Ça fait toujours rêver, je suis désolé.
It makes us dream. We're going to speak with you, Alexandra. We'll talk about an application that you worked on, that is called ODESS. It is an application that is developed by UNICEF for young women towards all the questions that they might wonder about their menstruation. First question, why did you use a digital tool, an application on that topic?
Fantastic question. Echoing what my panelists said earlier, we knew that girls had lots of questions about menstruation and puberty and sexual and reproductive health, and they're increasingly going online to find this information, but there's a lot of disinformation out there. A lot of this kind of information or the questions they have, they're quite private. Girls wanted something where they could ask them discreetly and they could get answers very quickly in the tools they used every day. So we spent, many months working with girls, co-creating with girls, primarily in Asia, which is where we first developed the tool, although it's spread across 14 countries across sub-Saharan Africa and Asia. But in Asia, we spent months talking to girls about how they get their information, how they wanted their information, and also trying to understand if there was a role for digital. And based on what girls told us and based on what they came up when they designed, that's how we came up with this digital tool.
Et avec une spécialité.
One specificity, this application, you don't see a GP, a nurse, or a physician that will give you advice. It is like an older sister that will give advice to the younger sister. Why?
Great question. So the way the app has been developed, we use an avatar which takes the form of an older sister. And when we spoke to girls, and we see this in every new market that we build Oki in, girls tell us that the kind of information they want and the questions they have are much more comfortable talking to an older sister figure because they feel they can ask broader questions at things they might be a little bit embarrassed about. So that was why we designed it like that, but girls told us that's what they wanted. We don't use like connections to doctors or to nurses for two reasons. One, for privacy. Privacy is a very big part of this application. We don't have anything like geolocation. We don't have anything that can identify the girls, but also connectivity. The app works completely offline. Girls don't need the internet to use it. The moment you link to a doctor or a nurse or a service, then you need the internet. And talking about digital health and gender, there's a very big gender digital divide for women and girls. Women and girls have much less access to internet and mobile phones broadly, but much more prevalent in parts of South Asia and say like West Africa. And so that's one of the reasons why we've built the app that way.
Et c'est une application pour vraiment voir à quoi elle ressemble que je vous...
It is an application we're going to discover now in a short video.
Aki, a period tracker app for girls like you. My name is Ari. Use Aki to get to know you by tracking what's going on with your body and mood every month and learn about periods in fun ways. Create an account and choose an Aki friend like me to accompany you. We are here for you every step of the way. This is your monthly menstruation cycle. Each shape is a day of the month. And this number is your personal countdown. It shows how many days until your next period, or how many days left of your current period. Track your mood, period flow, body, and activities with emojis on the daily cards. Write in your private diary card. Test your knowledge and take fun quizzes. Check out your calendar and see your whole month at a glance. And check out the Aki menstruation and puberty information to learn new things about your body and health. And don't forget to send me some love. Welcome, friend, to Aki. For girls, by girls, period.
Voilà, c'était important.
It was very important. We can really give them a big round of applause because it is a wonderful application. And it was nice to see because it's such a huge change. It's not just a medical information. It's designed by young girls. We are in aesthetics with young girls, with avatars that each one is going to choose according to her skin color. It is an adapted language. It is like a video game, a environment with applications, with everything that young people do today. This application was developed by UNICEF. It is open sourced. So does it mean that anyone can adapt it to anywhere, to anything in any country?
Yeah, what you saw there on the video is the global English version, but in the 14 countries where Oki is live, it's in each language that the girls choose. So Oki South Africa is in 7 different languages. Oki Kenya is in 2 languages. Oki Ukraine is in 3 languages. And as you said, girls, they design it in each country and then they choose the avatars. They've designed the avatars to them. So Oki is open source, which means that the code and the content and the brand was developed by UNICEF. But what we do is we give a license to one organization in each country who then takes on the responsibility, the franchise, if you like, to build Oki and be responsible for it and take ownership. So UNICEF were the beginners, but really it's now in the hands of other organizations across the countries.
Alexandra, vous avez...
Alexandra, beyond your contribution to okay, you have also co-drafted a report for UNICEF. It says, what do we know about a digital gap on gender? We're not going to have that much time, but in a few words, what do we know about this digital gap?
The answer is very little. We know that there's a digital gender gap for women over the age of 18. We know quite a lot from people like the ITU, the GSMA, and mobile operators. But for girls under the age of 18, we don't know that much. And this is actually a problem because this is a new generation. We need to start looking downstream as these girls grow up and they want access to information. They want access to services in a digital economy. If we don't know what technology they have and they don't have, and why not? My previous panelists mentioned social norms. That's a massive issue. We cannot design digital health platforms to reach girls. So that is a very big issue. I think we need to address the evidence gap.
Et toujours.
And again, keeping in mind the challenge, because we don't know that much of those young girls who are less than 18, to have access to a mobile phone or to internet. That is a real challenge and is not that obvious. And in social norms, it is not accepted everywhere. We should remember that.
Vous me citiez... Yes, pardon, allez-y.
Yes, go ahead.
No, I was just agreeing with you, Lionel.
Vous me citiez effectivement beaucoup d'exemples en préparant cette conférence.
Yes, you were quoting many examples of countries, but often the father, the brother, the husband doesn't allow a young lady to look at a screen on her own. And if you don't take that point, we can't really go forward with the digital help. Digital tool.
That's right. Worked a lot in Bangladesh. I think Bangladesh is a very good example of very strong gender norms about adolescents and adolescent girls in particular, and kind of a lot of fears of the negative side of digital rather than the positive sides for adolescent girls. So fears that, daughters might be approached by strangers on social media, fears that they might be doing things that are seen as like wrong in society. And so this often keeps girls offline from gatekeepers, so to speak, parents, mothers-in-law, other members of the community.
Assiatou, depuis Dakar, quel regard sur cette application que l'on vient?
Assiatou, what is your outlook? What is your opinion about this application from Dakar? I think it is really relevant and it is put back into context because we can see that in many other countries, in many languages, and it is exactly an example of something that is an innovation within a context, and then a context, and then it can target population and really contextualize the application. It's a very important idea. In 2022, your NGO Speak Up Africa launched with the African Union the Initiative for Women in Digital Health to make sure that women's health will be really well taken into account at all levels. Women who are very in rural areas, who are very far away from any health center. What kind of digital tools it could add for those people? The initiative is called A8, African Women in Digital Health. And the initiative is to bridge the gap between the gender gap. And really the initiative aims at promoting the whole participation of women and leadership of women within e-health. And this initiative highlights new ideas, entrepreneurs in the digital world who create innovations that are extremely relevant for the needs of their own community. therefore, those innovation people are creating digital solutions based on what they went through and what they had observed in their community, and they position themselves as activists and within their community, bringing the solution to the girls. It is a huge point of view because it's Pick Up Africa. You say you need to boost women, entrepreneur women. They need to take ownership of this and find and propose solutions themselves, so that they are. You've just created a mentorship program for entrepreneur women in e-health sector. What is it about? Well, it's a whole new program that was launched in July of this year, and it is a program it is a capacity building program, because here capacity building is a big pillar. So it is a capacity building program, as I was saying, and the aim is to identify mentors, women who are leaders in e-health, in digital health, and 5 have been identified. It was a bid for, it was a call for tender for young women who are innovating and who want to have access to leading jobs, so that they send their own CV, and they're very inspiring personalities, women who have succeeded. But very concretely, what are you going to propose to them? How is it to work? On what time schedule? Well, at the end of the month, we're going to have a boot camp in Kigali for 3 days. And the mentors and the mentees are going to meet, so to do capacity building around strategic communication, because even if we know that communication is really paramount for innovation, to explain what you do, many women do not have the trust or the tool to be able to present their innovation, to attract investors and partners, but also to boost an interest from different communities that will use this digital solution. We'll have 3 modules: strategic communication, leadership, marketing too, and product development. Because for MedTech, for health technologies and medical technologies, there are a few hurdles according to countries. You have countries where you need licenses, you need tests, etc. So you need to help them concretely to know what you should do before you can really launch yourself and before you can commercialize this. And you're saying it is important to have women who are innovating and proposing new solutions, because innovation for you, it's better perceived by a woman if it is designed and conceived by a woman. Absolutely. When Alexandra she's going to talk about it, but you have many topics in sub-Saharan Africa that are really taboo. Everything that is health, sexual health, and menstrual hygiene, and reproductive health. And maternity. There are women topics, and when innovation comes from a woman who would better understand challenges that come from those issues, the consumer, the users of this innovation, they are in confidence because they feel that this lady comes from our community, she understands our challenges, and on top of that, innovation is going to really address those specific points that are identified as real needs. So you're really moving the lines, you are boosting women to go forward, empowering them, you're giving them the tools through the mentorship to go further in their innovation. You can feel this energy. Can you see also all the ministry, the Directorate of Health Services, they're often hospitals, they're often men. Do you think they're going to move with you? In a conversation I was having with a lady earlier, I was telling her that nowadays things are changing because we are really aware now of the need to have women in these leadership jobs. And we're trying to work with African governments to be able to integrate gender perspective in public policies. It means that you can boost investment for women entrepreneurship, for digital tools and digital businesses, so that they can create the solutions for women and for the women by women, because financing in sub-Saharan Africa, and only 3% of financial help goes towards women startups. So there's lots of way to progress.
Initiative en Tanzanie.
In Tanzania, your organization does a lot for women. In one or two sentences, could you summarize what you are doing? Could you summarize what you are doing in one or two sentences? Because we know you are doing a lot.
For the opportunity. So we are her initiative. We are a non-profit committed to break the first of all, society norms for young girls and adolescent girls, especially in Tanzania. We have different interventions to make sure this, the norms are broken down. We have combining two ways, both economic empowerment and digital integration, together with to make sure these young women get access to sexual reproductive health education. So we are doing a lot of different things, but in summary, that's what we do.
Et vous aussi, vous avez...
And you too, you launched a mentoring program called Going Beyond, mainly for young girls. Could you tell us a bit more about this program?
So one of the programs that we currently have in our organization is called the Going Beyond program. This is a program for young entrepreneurs, 70% of it being young women. The biggest goal is to help these young entrepreneurs using a peer-to-peer model to reach a greater market, to move their businesses from the traditional businesses to now digital businesses, because we believe there's so much opportunities in there. We're not telling them to move away from traditional. We're telling them there's also an opportunity for you to touch that market too. So that's in general what we do. We use peer facilitators. So we bring a group of young girls and boys, 70% of it being young women. So we provide them with the education, with the resources, with the help from the Mastercard Foundation and Digital Opportunity Trust. We empower these, we call them youth leaders. These are facilitators now. And then after we've taught them, they go now to their communities and meet more young women and men, share the information from us that they got during the training of trainers. So yes.
Et justement, parce que c'est aussi...
Well, this is the theme of this e-health seminar, to develop this program and the information to young girls in Tanzania. What are the digital tools that you use and how do you use them?
So we also have, as one of our intervention, this happened after COVID. So we we opened first Swahili e-learning platform. It's called Panda Digital. So when you go to Chrome or any browser, you search Panda Digital, you get access to it. Unfortunately, it's in Swahili because it was designed for young women in Tanzania. So we're very proud of that, because there's not a lot of resources that are in Swahili that our people understand. So we thought that would be a great opportunity for them to come and learn using the platform. So in the platform, there's a lot of sections. There's a lot of things that we offer. But one of the most important things that we offer is called Ongea Hub. Ongea is speak. Ongea is a Swahili for speak. So it's a place where young women can come and report any cases of sexual harassment or sexual corruption that happens when they're doing their businesses. They also, sometimes they just don't have anywhere, somebody to talk to about maybe their mental health, maybe, what is going on with them because of the society norms, because of like the cultural backgrounds in our communities. So the hub helps them to, be connected with experts who will help them, who will talk to them and help them, and eventually connect them if there are cases where we have to connect them to like maybe courts, so we link them with a specialist that will assist them and help solve their problems. I wanted to add that on top of the e-learning platform that we have, that you can offer, we also have the SMS platform, because we believe not everybody has access to the internet, and the e-learning platform for now is reached when you are connected to the internet or bundle. So we have the e-learning platform. We use AI SMSing. So we have a special number. This is to reach people in rural areas, because we believe there's a lot of young women facing these challenges in rural areas, and they do not have these phones that has access to, internet where they can go and browse things. So there's a number, they send, they register themselves, they ask the questions. There's a lot of opportunities. There's a lot of things that they can do. But you choose what you want, what service you want, and then the SMSing helps you with that.
J'ai une question pour vous quatre au fur et à mesure que je vous écoute.
I have a question for the four of you as I am listening to you. This is a place here where we talk about e-health. We are very technical sometimes. We talk about innovations to do remote echographs, remote CT scans, very complex medical examinations. But I've been hearing some words this morning, such as information and choice for young girls about what they can do with their own body in the way they want, with their sexuality, with their reproduction potential. Is it my perception, or are we observing a change in needs? Is it true that needs are becoming less technical and more societal?
Yeah.
I think there is a lot of social and cultural factors linked to health. And today, in sub-Saharan Africa at least, women have a new freedom, a new understanding that they didn't have in the previous generations. So with some social and cultural hurdles, such as early marriage, which is quite widespread in sub-Saharan Africa, women realize now that they do have a choice, that they have the right not to get married early just because society tells them to, or they may decide not to get married early or not to have children early, and women make the choice. They can decide on what contraceptive to use, and they follow training courses a lot more than they did in previous generation, because that was taboo. There was no information around these subjects. So the fact that they have more choice now, and the fact that they are more aware of their freedoms, gives the possibility to women of making health choices. I turn to Alexandra. You are in Asia. We've talked about the example of sub-Saharan Africa. In Asia, do you have the same challenges? Is there this strong need for information and choice for the girls about what they are going to do with their bodies?
I think we're asking, right? And that question about needs, we are learning that to truly design an inclusive digital platform for girls that they want and need, we're actually asking them about what they need. And so your examples of how we've traditionally thought about e-health, I think that's where the shift is. Obviously, what fellow panelists said, absolutely. Just thinking about the digital thing, I don't think it's necessarily new. I think we're just asking different questions.
Nelly, je voudrais connaître également votre point de vue sur cette question. Ce sera...
Nelly, could you give us your viewpoint on this? Alors.
Of providing information. Of course, we are advocating for choice because it was one of the gender norms that we're dealing with, because we know that traditionally women did not have a right to choice. The decision was made on their behalf. So really, we are just trying to work on the social norms that traditionally have made it a bit difficult for women to stand up for themselves. And this is something we are doing so that as young as 10, 11, 12, depending with context and where you're coming from, then young women are able to stand up for, to stand up for an informed choice. And like Alexandra has correctly put it, so we are not working alone. We are working with the adolescents themselves. We are working with the youth themselves, so that whatever program we are coming up, whatever innovation we are coming up, they are at the center of it, and they're guiding the process and telling us, this is what we want, this is what we think will work for us. Even in terms of messaging, like I said, the issue in Kenya, you cannot just talk about comprehensive sexuality education. They are telling us innovatively say reproductive health, innovatively say age appropriate, because the kind of content we'll give a 9-year-old is not the content we're going to give a 15-year-old.
Ouais, on voit comment dans ce monde de plus en plus globalisé, les réseaux sociaux amènent.
Now, social media lead to massive changes on all continents. Thank you for the four of you, and remain here with us, because there will be questions to you from the room and from the internet as well. Before we have a session and answer question, let's go to Lomé, to Togo. In Lomé, there is a whole day of reflection on digital health in Togo. And you are attending our ODESS conference here in France, Toulouse. Giscard Kofi-Sambwe is a coordinator of the Foundation of Pierre Fabre in the country. Can you hear us? Who is with us today, with you today, Giscard? Can you hear me? We can hear you perfectly well. Unfortunately, the sound is not good. There's a lot of echo. We can't hear. We are together with the ministry. With we apologize, the sound was not good. You talked about e-health in Togo. Now, what are the work you're doing at the moment in Togo? I apologize. The interpreter apologizes. We can't hear well. There's too much echo. Interpretation is impossible because of too much echo in the room. This is unintelligible.
Mais également des applications, des sites internet, des cantines, pour pas dire des formations sur comment gérer les conflits menstruels, sur les questions de santé sexuelle et reproductive, mais pas seulement cela, mais aussi des initiatives qui viennent du ministère de l'économie numérique en matière de la cybersécurité, de la digitalisation, des schémas directeurs pour l'élaboration du plan stratégique national de santé numérique. Voilà, et aujourd'hui, on pose la première pierre pour la construction du Centre national de santé digitale vidéo.
The moderator is probably going to summarize for you, as we cannot interpret this. Sorry. Thank you for this. One last question for you in Lomé. Can you see yourself in what has been said in this panel? Can you recognize what you're doing? And do you have a question for our guest speakers?
Ah oui, c'est comme à Pierre Fabre, comme ici à la Fondation, le micro circule dans l'amphithéâtre de l'Université de Lomé et on va pouvoir entendre.
They're circulating the mic in the amphitheater of the University of Lomé. Let us see if we can hear the question. We work on women and young girls. No, sorry, we apologize. This is not doable. Very sorry.
Inclure les hommes qui sont des moteurs donc, de la culture et qui perpétuent les éléments socioculturels. Donc, je vais faire un peu de pour les panélistes, pour les ceux et celles qui ont présenté des projets, pour qu'on puisse inclure donc, les champions jeunes hommes et puis dans cette politique de changement, les exemples qui vont par rapport à.
Alors, je vais reprendre votre.
I am going to summarize your question and ask you, Setou, perhaps, how do you include men, the young generation of men, because we talk about young women, but how about young men? Do you see any changes in the young men's generation?
Thank you for the question. I think that's a great question. And we get that every time when I speak about working with young girls. So our goal and mission is to work with young girls, but we believe in the communities that we live in, there's also men there. So in all of our approaches, there's, for example, with our Panda Digital, it is designed by women for women, but young boys and young men have access to it. If you go there as a young man, you sign in, you log in, it won't log you out. But we are saying this is particularly is for the girls because, there's been a challenge for them to access this information. So we're like, this is for them. And the biggest percentage, there's about 7,000 people who've reached the platform and 95% of it are young girls. Right. But the men and young boys are there too. In all of our other interventions too, young men are there. For example, the Going Beyond project that we currently do, 30% of it are young men. We believe in the integration of both. So we do involve young men too.
D'autres questions depuis cette salle ici? Voilà, le micro est au fond.
More questions in this room? Yes? Have you found a solution for these to continue existing? Because maintaining active application costs a lot of money. It seems simple to use, but in fact it's very complex. There must be continuous development, and that costs a lot of money. It is complex to publish them as well, to remain present on the platforms. All these are hurdles. Have you got in mind a solution? Because these are not NGOs we're talking about. We're talking about very small structures, very small initiatives, and how can they be supported? This is a very good question. In fact, we've been able to observe that there is a sustainability problem for the existence of these platforms, above all for the small organizations who are in need of funds. And we are promoting now collaboration and strategic partnership to ensure durability. So these women entrepreneurs, we put them in contact with renowned investors who can help them maintain encourage durability, but it is not sufficient. We also work with governments so that these women entrepreneurs can take part in the working group that they have at ministry level to make sure that there's always a link between the innovation that is created and that responds to a specific need at the ministry. And thanks to this, these women entrepreneurs always know about new funds and new opportunities that are available in their sectors. And there are communication channels that are always opened between the Ministry of Health or Digital and these women entrepreneurs. Yes, applications are created, they cost a lot of money to develop, but then every month you have to pay for licenses, maintenance work, and there's always a lot of costs involved.
This is a question for all of you, and it's about the intersectionality between gender and disability and neurodiversity. But first, I love the approach of nothing about us without us. Like all of you are taking that approach, which is hugely commendable. How have you thought about those women or adolescents that are marginalised due to disability, cognitive impairment, or neurodiversity?
Qui est-ce qui peut répondre? Nelly?
Yeah, probably I can go fast. Like I say, our target group is adolescent girls and young women in all their diversities. However, we also take note that working with, especially those with disabilities, takes a lot of investment. And I will talk about our network of providers. Our providers provide services to those with disabilities also, and our facilities have been set up in a way that they are accommodative of whatever disability then the adolescent girls and young women walk in. Our areas of focus, of course, we work in rural communities and peri-urban areas, and this is where you get a lot of this population. And just mentioning that they come with compounding vulnerabilities, disability being part of it. So our way of providing these services is integrating health, sexual reproductive health care. So it's a one-stop shop. You're not coming there for HIV, or you're coming in as a result of rape, and then we are referring you to facility X for HIV, facility Y for no. When you get to a facility, by the time you leave, you've gotten all the services, including referring you to a lawmaker if you're a case of GBV, and also ensuring that there's a lawyer on standby to provide pro bono legal support in case you need to take the case to court. However, disclaimer, this is quite financial intense because the lawyer has to be facilitated. Just the whole process of also just setting up the whole holistic care is also, resource intense. Yeah.
Le temps pour une toute dernière question rapide.
One very last question. Merci.
Nelly, you actually answered a part of it regarding the pro bono legal support, but I wanted to ask you, because Kenya was one of the few countries that came up with the digital health bill last year it was released. Like, how do you actually because it extensively talks about the data governance, and the data that you are talking about is personal sensitive health information. So how do you actually govern that? And then, because having a law is one thing, but then ensuring compliance, because you are actually providing this service. So how do you take care of the security and confidentiality of this sensitive information that is residing, like where does it reside? And how do you take care of that? And then how is it actually taken care by the legislation? Thank you.
Yes, thank you so much. And so just to speak a bit about Kenya having domesticated the WHO 2019 reproductive health guidelines, digital bill is part of it. We have the whole primary health care bill that then allows us to take the services to the community, giving power to community-based distributors, and forgive a lot of jargons that I'm using. So the community health promoters are very critical in ensuring that primary health care starts right at the household, and that's where telemedicine and digital health is all anchored to. Talk of consent. Consent continues to be a very big issue in Kenya, and this is because age of consent, according to Constitution, is 18, but we have the Health Act that then allows you to access services, and as a healthcare provider, you come in, you're 15-year-old, you're a young person, you're in need of services. We have a whole adolescent and youth reproductive health bill. Yeah, that I know is being revised, but the government is very clear that even young people, as they come in and they need services, then you as a healthcare provider, you have to make that decision to make sure that you're providing services. At organizational level, we have an ERP system that allows us to protect the client data. And our data, they know that it's only provided to the government and our donors. And where we need consent, especially for photos now, because that's very sensitive, we are getting consent before we provide any information for the clients. Did I summarize?
Merci. J'ai le difficile rôle de gardien du temps.
I have the difficult role of timekeeper. This is absolutely fascinating, these testimony concerning the field. This is fascinating, but we can give you all a round of applause for this magnificent panel. I'll let you go back to your seats, and we are going to continue now with another approach, which concerns us as well. Violence against women. How can new technologies be useful in this field? Patricia Mecheal, co-founder of Health Enabled, an NGO on the global health of people. And they use, amongst other, artificial intelligence. So you have the mic, and we are listening to you.
Thank you. Is this on? Can you hear me? Okay. Thank you. I'm going to start with a story. When I was 9 years old, I was in Egypt. My family is Egyptian. I grew up in the United States. I was in Egypt. I'm not even sure how this all happened, but I was left alone in the house with a family friend. And that family friend grabbed me, tried to kiss me, and I kicked him and ran for my life. And then the family came out looking for me, and I was brought back home and grounded for the rest of the summer because I had run away. So today I'm going to talk a little bit about the use of technology for prevention and response to sexual and gender-based violence. It is not a topic that I particularly enjoy speaking about, but it is a subject that really needs a whole lot more attention than anybody is actually giving it. And I want to appreciate Renu because I'm actually a professor in an academic institution in the United States. So when you gave that example of like, oh, you could be, this is something that I think impacts a lot more people than we actually really think about. So just really quickly, the organization that I work for works at the intersection of whole person health. We believe that we all need to be looking at health, whether it's mental health, emotional health, physical health, in a holistic way, much more so than we currently do. Equity and technology in everyday life. And we focus on health equity and well-being for those most at risk of being left behind. We also have an initiative called the Global Digital Health Monitor, where we measure and monitor the state of digital health. And in the last iteration of the monitor, we included an indicator on gender. And what we find is that in most countries, gender is inadequately represented in national digital health strategies, in national governing bodies. And at the same time, women's mobile phone ownership is a really good indicator alongside health outcomes of improved access to health services and health information. We're also seeing that there are new risks that are coming with technology that impact women and girls disproportionately, including technology-facilitated violence. So I'm not going to ask by show of hands how many people here have either experienced or know somebody who has experienced sexual and gender-based violence, but just to say that 1 in 3 women worldwide have experienced some form of physical and or sexual violence in their lifetime. 6% of women report experiencing non-partner sexual violence. So I really appreciated the presentation before where they were talking about access to different types of services, particularly in the case of rape. And that this has remained consistent over time. During the COVID-19 pandemic, we saw a significant increase and spike in domestic violence because people were stuck at home. Tension was high. Very challenging. In terms of technology-facilitated violence, we're seeing that new forms of violence are emerging, including when you were talking about getting permissions for photos that are being taken, there's a lot of deep fakes that are being generated. Young women's faces put on bodies. They can't undo that. And so there's a whole realm of things that are happening that, you know, need to be more discussed and addressed in through this work. And it's not just physical. So there's physical impacts that happen as a result of this, but the impacts are much larger than that. And, you know, there are mental and emotional challenges that last beyond the initial violence. There is the social impact, the stigma, the discrimination that comes from this. There's also economic impact, which I, was genuinely surprised to see that the cost of sexual and gender-based violence on the world is over $200 billion. $200 billion. And that the impact on the family and society, that you have intergenerational violence, you have violence that kind of carries on, and there's a cycle that continues on to the next generation if it's not addressed earlier. So years ago, I was engaged in a previous life. I was the executive director of the M-Health Alliance, and we commissioned a piece of work with CARE on addressing gender and women's empowerment in mobile health. And in this piece of work, I remember my colleagues at CARE raising the importance of including, you know, gender-based violence within this framework. And I was just like, oh, like why would we do that? Like, I wasn't even like thinking about gender-based violence as part of conversations around gender. And she very, you know, quickly, you know, explained to me, and I was really grateful for Ranu's conversation this morning around power dynamics. That a lot of times the issue of sexual and gender-based violence is a power dynamic conversation that you have. There's a lot of fear among women and safety concerns among women that have to be accounted for when you're looking at gender within the context of the use of mobile technology in health. There have been situations in which health workers are afraid to go out into communities with tablets because they're afraid that somebody is going to, you know, hurt them to steal the tablet. And so we have to really broaden our viewpoint on some of these things to take these things into account. Sexual and gender-based violence encompasses a whole range of things. And one of the ones that I wanted to call out is that now we have more conflict in the world than any point in time. And there's a lot of gender-based violence happening in a lot of these conflict settings, which is horrifying. We heard earlier, you know, mention of early marriage. You know, there's female genital mutilation. There's a number of different aspects of sexual and gender-based violence. A few years ago, Health Enabled was approached to lead a body of work to really try to understand the ways in which technology is being used to prevent sexual and gender-based violence and respond to it. And what we found is that there is a fair amount of work that is happening, but it's happening in like little pockets here and there, and it's not very comprehensive, and it's not kind of well designed. I think the example that Nelly shared earlier about this connection and this ability to connect work being done from a prevention perspective and a community engagement perspective to health services to then also engage in legal service support is really, really critical. On the prevention side, what we found was a lot of use of technology for gender and social norms, so engaging young girls and boys in gaming so that they can better understand and grow in terms of their own knowledge of what it is to be in a respectful relationship, what it is to engage with, you know, with their own groups as well as the opposite sex in a respectful and responsible way. And we find that in the prevention side that it has to happen younger and younger, that we actually need to engage with children to really explain to them, like, what are your rights? What should you be thinking about? What are the conditions in which you can develop from a healthy developmental perspective? We saw a lot more on the response side in terms of reporting of incidents of sexual and gender-based violence, and then using even things like AI and chatbots to support the prevention of secondary, so, you know, continuous incidents of sexual and gender-based violence, and some overlaps between the two. Ranu mentioned the use of important frameworks as part of the work that we do. The RESPECT framework from WHO is a really good one to really look at, you know, the range of considerations that have to be accounted for when thinking about prevention and response to sexual and gender-based violence. And then in terms of some of the outcomes that we mapped in this is such a new area that there isn't really a lot out there. When we first started this work, we were very ambitious. We wanted to develop a theory of change. And there was really no way to develop a theory of change. Nobody had ever really studied this. Nobody had ever really tried to put some sense to it. And so what we wanted to do was at least identify what are some of the outcomes that are related or that we should be focusing on, trying to aspire toward in these areas. And some of these areas are things like improving, gender norms, improving self-efficacy. So the extent to which, you were talking earlier about choices, the extent to which, women have choices and options. We also identified some special considerations for children. There's a lot of violence against children, and they require a whole other set of key considerations, both in terms of really understanding, how to find themselves in safe spaces, how to protect themselves, engage with trusted adults, and then also in terms of how you communicate with young people. So just wanted to share, that sort of brief introduction in this and contextualize, sexual and gender-based violence within a broader conversation around gender and digital health. And then to introduce another sort of piece of work that we work on at Health Enabled, which is really around gender intentional digital health. So this morning we heard the difference between being gender sensitive and the difference between being gender transformative in terms of, and so what we really need is to be focusing to the extent possible on being gender transformative, that it's not enough to take into account gender considerations. You actually really have to understand the context, you have to understand the culture, the social considerations, and really aim toward transformation. We do a lot of research at Health Enabled, and a lot of our research is gender sensitive research. And what we found is that when you take a gender intentional approach, that the impact is here. When you take a regular approach, your impact is here. And so what we're finding is that even, in looking at gender, and then when you look at gender, be sure to also, take an intersectional approach where you're looking at all the considerations around an individual. But then the impact can be a lot stronger. And we found that you need 3 keys to doing this. You have to analyze the situation. You have to analyze the situation. You can't just include a gender activity in your program without analyzing the situation. Then you have to really design with the intention of overcoming those situations that you find in your analysis, and being more gender transformative. And then you also have to monitor and evaluate. You have to, because that which is measured gets done. If you're not measuring and monitoring, it is not going to happen. And so I will end there. Thank you.
Pour cette présentation extrêmement.
Thank you for this very moving presentation. We are going to continue this conference, and we are going to listen to Nusura 2024. This new project is Neo-Tree, developed in Zimbabwe and Malawi to fight against infant mortality and decision-making support tools.
Our project is called NeoTree, and our goal is to end preventable newborn mortality. Every year, 2.3 million babies die within the first 28 days of life. And of those 2.3 million babies, around 2/3 or 70% of those deaths could be prevented, not through providing really expensive equipment or drugs, but just through delivering the basic care at the right time and the right place for every baby. It's a digital tool, and it aims to deliver evidence-based care to every baby at the bedside, and also collect data, so information about each baby, about why they've been admitted to hospital and what treatment they've received, and also to guide the nurses and doctors at the bedside to make the right clinical decisions. There are 30 million small and vulnerable babies born every year and cared for in low-resource settings, and so our mission is to catalyse the digital transformation of care for these babies. And our hope is that the NeoTree or interventions like the NeoTree will be used at the bedside for every one of those 30 million babies every year. And we also want to change the culture, or be part of the narrative that changes the culture for the use of these types of tools within health services, within low resource settings.
Voilà, NeoTree.
NeoTree prize winner, Observatory of e-health in the southern countries, and NeoTree, she's going to join us on stage, and we can give her a big round of applause. Give him, sorry. Please, Simbarache, come and join me. You're going to be given a mic. Simbarache Chimuya, well done for this prize, well done for this initiative from NeoTree. We have some feedback now about what NeoTree is doing on some part of the area you're addressing. Do you have a more general feedback for both countries on reduction of infantile mortality, but also capacity building of the e-health system, of the health system? Do you have any feedback?
Okay, thank
Just come next to me.
So our e-health system has been implemented at 2 hospitals in Zimbabwe and 3 more hospitals in Malawi, and also primary health care facilities. And at the moment, we are also increasing the number of healthcare facilities that will be using this digital platform. And we hope that by the end of next year, we should have increased to up to 17 healthcare facilities using this platform to care for newborn babies. We also have other benefits apart from just mortality reduction. I think things to do with rational prescribing, minimizing unnecessary antibiotic use in newborn babies where they're not quite indicated, because the platform is going to guide the healthcare practitioner on the bedside to choose the right decision where antibiotics are needed or they are not. And we also have deliberate efforts to train the healthcare workers on newborn care. And so we have reached to a number of healthcare practitioners, I can say more than 1,000 in these facilities where we are operating, who benefit from these educational programs and workshops and, refresher courses on newborn care. And that's another benefit which we bring through this platform. We also have, audits that we do because we now have data which is not easily available on newborn care. And this data is used to, assess how we are doing in terms of providing care, what are the major causes of morbidity on our units, what are the major causes of mortality, and we take deliberate actions to teach and train our healthcare practitioners, addressing those major issues. For example, I can tell you that we managed to cut down the number of babies being presenting with or admitted to our unit with hypothermia, because we realized there were a lot of gaps in preventing hypothermia within the unit itself. And so this data came out, and we saw the need to address such kind of challenges, and we deliberately started the educational program, how to prevent newborn hypothermia throughout our unit and also the maternity facility. So this resulted in a drop in the, proportion of babies who were coming to our unit for admission with hypothermia. It was really drastic drop. Yes.
Félicitations. Lorsque je vous écoute, Simbaraché, j'ai vraiment...
When I listen to you, well done. I feel that your system in Neo3, it's an application that gives a wonderful technical progress, because you need monitoring. It's very important for newborn babies. But then what I can see is the cultural progress, really, on the way you are taking into account new ideas that practitioners and GPs are changing their habits. Why not? What do you think about that?
Indeed, we would like to see a change of culture in the way the healthcare practitioners who look after newborn babies. And we not only want to see that happening or affecting people at, higher level institutions or central hospitals, but we know that there are a lot of babies who are cared for at the primary care facility level by nurses and other practitioners who may not have a sufficient training in newborn care. So the more facilities we reach out to, we know the more the number of newborn babies who would be cared for by well-trained practitioners at all levels. So this is our hope.
Vous allez recevoir là dans quelques instants, Bertrand, pendant...
You're going to get your prize. Thanks. Please stay with us here. Stay with us, Simarache. Thank you. Stay, because we're going to give you your prize. My last question. Pierre Fabre Fondation is giving you this award. It's not just a nice award on the desk. There's a whole support from the foundation to develop your project further. What are you expecting today from the teams of the foundation, Pierre Fabre Foundation? What are your expectations from the team?
Very much. Firstly, I must say we are really honored and really proud as a research project to be visible and be seen by such institutions like Pierre Fabre Foundation. I think we would like to be connected. We know there are a lot of other institutions out there who are doing various things, and it's an opportunity for networking and sharing notes and learning from others what other people are doing, which I think a foundation like yours is able to bring us together and make this networking. So I think going forward, it's one of the ways to really survive in this world with the support of other groups as well. I think there is a lot to learn, and I have a lot to learn from the groups that are here, which are doing fantastic work elsewhere. And I think we are going to, sharing notes, and there are a lot of things that I can adopt into our work as well. And I hope they also, a lot that they can adapt from our work into their work as well. So this is the beauty of having Pierre Fabre Foundation bringing us together here. Thank you so much.
Quel très très beau message, rassemblé sur.
It is a wonderful message, gathering, sharing good practices and going forward with the same aim. Bertrand Parmentier from the expert group from the e-health, so we can give you the award immediately. Bertrand, please take a mic. Why did you choose from the expert group these Neotri? Why did you choose them? First of all, it's a platform that is open sourced, so really it's a big merit. Then it was really, we were very happy, and we love this project because there's a learning, spreading good practices and collection of data that was shared so that medicine could go forward with a dynamic that is centered on the patient. The second point was the speed of the scaling up. We are now working with 2 countries with many hospitals, so this dimension of sharing that Simbarash said is operating as from now, and what is really remarkable, it is the heart of e-health, is that now we have tools that do not need lots of capital, and we have a wonderful leverage for public health policies that are addressed to everyone, and that is paramount in countries where people are very often isolated and extremely living in poverty. Bertrand Ducoin, Neotri, please come. Simbarashi, come at the center of the stage for the photo. It is a price with 40,000 euros subsidy, and we hope it will help you scaling up more and carry on having all the successes that you have with Neotri. And thank you very much for sharing all your experience, because it is the aim of ODESS is to do some network so that we can have feedback on e-health. Thank you very much, and well done again. Congratulations.
Voilà. Et l'ensemble.
And the whole of the team is here, a Neotri team. Thank you very much. Last award winner from this 2004 year. It's eHESA in Rwanda. It's a digital platform for collecting patient data. Up to now, they were collected on paper, and here we have digitalized this data collection, so the analysis is much more precise, and we gain lots of time for the health practitioner. We can see that in the image. We need to improve data and analyzing of data collection and analysis.
eHESA, it's an innovation of TIP Global Health. Iheza, its Kinyarwanda name means bright in future. It's a point of care.
Subtitles on the screens for translation. Thank you.
Care to support community health workers, nurses to move to the journey of paper to digitalization. We had made sure that all their paperwork has been digitalized in a way that is comprehensive to simplify their workflows, the time they are spending doing different activities, but also in a simplified way that allow them to diagnose, treat, provide medication, as well as transfer across different levels of care, primary health care, but beyond. After collecting those informations, analyzing them was also another big challenge, especially for healthcare workers. So when you do this on paper-based, it can take months and months, but when you digitalize this in a way that is simplifying the flows, access to data in real time, data can support to tailor education to each patient based upon their specific needs. And on the other hand, that also as decision makers, not only for community health posts or health facility, to Ministry of Health as well, that we can use to do our regular decision, but in real time. It solves some of the biggest challenges or the problem they were facing at that moment.
Projet IESA lauréat.
Well done, wine prize winner for the IESA, Teophilia Orero, is going to join us to get this prize. Came from Rwanda. Well done. Teophilia, join us from Rwanda. Teophilia Orero Uwakuyo, near Toulouse at Pierre Fondation in Pierre Fabre. You moved.
Rwanda and all Africa, especially my team who are staying in Rwanda and beyond. We are excited to be in this platform and hope to build the network that will support all our work.
Ouais. On voit le travail formidable qu'on a vu en image que vous avez fait sur la...
We have seen the wonderful work you have done for digitalization data. Can you measure the impact of this digitalization for your for digital health?
The impact in how the digital platform can contribute to the improvement in health outcome. We have been also assessing how IHESA is contributing to the reduction of malnutrition for children, having women accessing to NC activities, antenatal care activities, but also have been measuring how IHESA is contributing to the quality of care being provided by healthcare workers, where we are assessing through a checklist how are they performing all activities without missing any activities, because by missing HIV tests or by missing testing for anemia, you can have a child being affected by HIV. So through IHESA, there is a way it does support you to improve the quality of care you are providing, but also how does digital platform contribute to the efficiency in terms of time, quality, and cost. Those are different ways we have been assessing our impact. So it has been reducing the time through the manual administrative activities, also giving the healthcare workers, nurses, and community health workers a way they can be able to generate sufficient performance based on finance, based upon how they're using IHESA. It is pushing them to cover everything, and also making sure that when through the evaluation, they have been focusing on every activities as per requirement for Ministry of Health.
Ce serait un système facile.
it would be an easy system to duplicate to other countries in the world?
EHESA, we have been ensuring we are capturing all the flows, especially in Africa. You know, there are activities happening by individual, and then most of activities, they're also happening by groups. So you can conduct health assessment by group or by an individual context. And also it's offline and online platform. You know, in Africa, the internet is another challenge, but also it has been customized into different languages. Now it's in Kinyarwanda, Kirundi and English. Soon we'll be translating EHESA in Somali.
J'ai envie de vous poser la même question qu'à Simbarache tout.
I want to ask you the same question as Simbarache earlier. And of course, there's a financial help, but we're here in the foundation. We have a know-how, experience, expertise, I would say, to develop, that we have been developing over years on the e-health projects. What do you expect from us, from the foundation teams?
Expecting various support. We hope, since we are planning to scale our work, we have a vision of 10 years in 10 countries. So we hope we are going to build a network for people who will be more interested in EHESA work. There are many partners here, whoever interested in having a full comprehensive primary care ecosystem app that support both community health workers and nurses in one application, not various applications. So please feel free to reach out. And also we'll be learning and also sharing all the lesson learned from different cohorts here. And through this platform, we hope also we'll be receiving some support from people, partners here on how we can strengthen our strategy for scale-up.
Profitez de l'expérience des autres. Et pour remettre ce prix, va nous rejoindre tout de suite Béatrice Garrett.
Please enjoy and Béatrice Garrett, who is a head of the Pierre Fabre Fondation, director. She's going to give you the prize in the name of a future foundation. The president, Manu Louvier, couldn't make it, so she asked me to be her voice here. So I'm going to say the Foundation for the Future, la Fondation de l'Avenir. It is a partner of the observatory that is supported by the mutualist movement. Its task is really to work with the whole of French researchers in order to improve health practices. They started with surgery, and they have prizes with financing envelopes that go with it to develop new approaches, and now with all health disciplines. They're also working very hard on digital health, and they have joined us at the observatory because they thought that what's happening in South countries was really very good, instructive to try to find solutions in countries like France. So we also have to raise health challenges. So I'm very happy to give you this prize in the name of the Foundation for the Future, Fondation de l'Avenir, and in the name of the Pierre Fabre Foundation. Why did you choose EHESA? I must say that EHESA, let's say, they ticked all the boxes. They ticked all boxes. We have an expert committee, Bertrand Parmentier, Professor Barbele Yoko, and we have some criteria to choose the final stage after all the inquest, and in the final stages we have many criteria. You need to talk to vulnerable populations, have a medical service that is proven, to have seen the effects, to work in open source, in interoperability, to be linked with media authority. So all this. So we're talking to vulnerable population, to men and women. And I think what is remarkable is reinforcing capacity of agents. And in many countries, these people who are from the community who are trained to give first care and orientate family, they are a very important link in the healthcare chain. In many countries, they are recognized and they have been given a salary now, and they're here to support many NGOs initiatives. If they were not there, we couldn't deploy programs. So this building and reinforcing is very important. There's also a data use that is very smart. smart. And what I loved was the real time. That is to say, to use data in real time, not just to make reports, but also to help decision making on the field. And this data was shared because it was built up with the healthcare authorities. So it's going to help the roadmaps of the health ministry to give a better priority and better means to the public health services. Thank you, Beatrice, with a photo. Thank you so much. Well done. Okay, well done for this prize that is going to go to Rwanda. To finish with, you stay with us, please, because we have. Please stay with us. We're here with the internautes as well. So please, from Lomé, you have questions to ask. From Uni, you've been with us live, Giscard, and all the people who are with you in this Uni. Do you have questions to ask to those prize winners?
Question? Sinon, moi, j'ai une question.
Allez-y, on vous écoute.
Quel conseil pourriez-vous nous donner pour la création d'un lieu similaire au Togo?
Pour la création.
What advice can you give to create a similar project in Togo? Both. What do you think? Teophilia, what do you think? How can you duplicate this project in Togo or somewhere else?
I think the most important is to first understand the challenge or the issue you are facing, especially you, the healthcare workers, and the entire ecosystem, like a government and whoever that you are trying to support. And also through that, it's really important that you co-design together to make sure that any solution or any digital platform you're bringing is solving those challenges. And also always make sure that you are in line within government system, but also you are using the tool that will be easily adaptable to your context. So if you are working with maternal child health, make sure that all the WHO protocols, Ministry of Health protocols are being followed, but also do you have internet issues? Make sure that your system can work on and offline. Are they going to use data not only for decision makers? We usually forgot healthcare workers, and yet they need those data to improve the quality of services they're providing. Thank you.
Simbaraché, je vous pose la même question.
Simbaraché, I'm putting the same question to you. Is there like basics that would be financial basis that is absolutely indispensable to be able to duplicate Neotree somewhere else? What do you think? What are the basics to duplicate Neotree in another country?
I think one of the crucial things is to work with the frontline healthcare workers in those institutions, in those settings, in developing the system, understanding where the gaps are, understanding what their needs are, so you develop it together. There is also another caveat where you need the policymakers, like the Ministry of Health. What does their policy, where does it stand regarding such kind of an innovation? So because this is going to be very important when it comes to scaling up in those settings, you need that ministry backup so that you can reach out to as many institutions as possible. So bridging those gaps and making that relationship with the Ministry of Health, who are the policy makers, when you want to introduce such kind of intervention, I think that is very, very important. Thank you.
Merci. Il y a des micros qui vont circuler.
Thank you. We're going to give mics to the in Kinshasa. We have Yannick, and Yannick says that he's very excited to take part in this conference because it is a topic that is not really being accounted for in my country. Thank you very much, Yannick. Big hello to you. Other questions for all prize winners or any observations?
On apporte les micros. Assiatou.
So I'll go ahead and ask my question in English, and it's for Theophilia. Thank you so much for sharing all of this. It's such great things that you are doing with this innovation in Rwanda. My question is more so around scaling up. So you talked about scaling up to 10 additional countries or 10 more countries. I'm wondering what the criteria for that scaling up is. Is it based on the country's readiness, or are you taking other factors into account?
Thank you.
C'est bon.
Thank you so much. To scale our work, we are taking into different consideration. We are assessing the countries that are facing the same challenge as what we are facing. And then also we are making sure that we are meeting the countries which have a partner that can support us to scale. So, the partner who really understand the context, who have strong partnership with the government, who can support us through those navigations, but also can sustain the work through the implementation. On the other hand, we are also waiting for interest that may arise. So that's where also we can discuss and see how we can collaborate, because mostly we are focusing on the customization based upon different needs or different country contexts. But the key main focus has been focusing on the government needs, and then we find out how we can scale through the partners who can sustain the work.
D'autres, voilà, micro.
Merci. Florian Tréclin de la Fondation Terre des Hommes. On a parlé beaucoup
We talked a lot where we can see these projects are interoperable. The data collected can be integrated in the national health information systems. So my question is, are these data used by the governments, by the health authorities? This data can be integrated, but is it used really, and how?
Our work with National Child Development Agency, where they reached out, they wanted us to support them to digitalize the child scorecard, where we'll be giving them different dashboard from the village, the lowest government level, up to the national level. The dashboard are customized based upon different needs, and through that also they are reporting according to what they were not able to manage. The village, they're reporting to the next level. The next level are also reporting to the government. They're not fully managing the entire issues. They are managing what they can be able to manage at their level, and then government or National Child Development Agency will use that opportunity to solve the challenges that were not solved at the district level, but also at the sector level. So that's another way of using data. Another example is we have been working with the health centers and community health workers for they are all public institution or Ministry of Health staff. So they are also using data during their coordination meeting. At the health center level, their monthly coordination meeting, that's where they can use data to inform people. You have such indicators, you have a drop in malnutrition status, or you are having a severe malaria or severe anemia, what are you going to do next? And then they can report to the other level. Yeah. Thank you.
Reste-t-il quelques questions, commentaires ou félicitations? Non.
Any questions, comments, or congratulations for our speakers? Madam, yes, that will be the last question.
And if I understand correctly, like in Rwanda, I'm assuming there are like various public health reporting requirements. Is there any consideration about any kind of public health reportment requirements on your platform, where the platform can satisfy that requirement so that physicians don't have to use a separate system for tuberculosis, separate system for HIV, separate system for something for the requirement?
So thank you. Where EHESA is being implemented, we have a comprehensive package. For example, for community health workers, all their package is fully like a digitalized. There's integrated community case management. There is nutrition, community-based programs. There are many more activities. They are full in one platform, and through that platform, they can refer to the health center where also the full package will be there. So within one platform, you don't have to use a singular tool to diagnose HIV or to diagnose TB because they are already in one platform.
Merci à tous les deux. On peut les applaudir une dernière.
Thank you both. A round of applause to both of you. Thank you very much. We are coming near to the end of this 8th conference of the Observatory of e-health on digital tools against gender inequity. And I'll give the floor back for the closing words to Jay Ganesh, Executive Director of AIN, the Asian e-health Information Network, which is a partner of this observatory. And I'll give him the floor to conclude this day.
Thank you for the motivation. Yeah, I think it's an easier task, and it's also a tougher task because we are in the end, and I don't think there is anything much that I could share as something new at the end of a very rich day. But I would like to start with something that a confession. I'm not an expert in gender equity, but I have led teams. So I'm sensitive to the fact and consciously try to actually put the things into practice. So I'm more a practitioner. But then, I think this is also an occasion. There are plenty of tools. There are plenty of frameworks. There's no doubt for that. And then I'll also be showing one of the health equity framework, but then there will be more frameworks coming out. But where do we go from there? After getting this opportunity to come together and then sharing our respective experiences from at least, I would say, at least 3 regions, minimum here, and then 4 regions, yeah. And then where do we go from there? I think that's more important. What do we do in our own incremental steps? I think it's like each drop will actually make an ocean, and a big journey actually starts with a single step. So I'm more interested to try to actually take you, what is that we can do after this event in our own small way or big way. So a reminder that while we are talking about gender equity and digital health, but our focus is health. So just a reminder, it's not that you have forgotten, just that I would like to start with a reminder of that.
And digital health, like I think this is something is understood, that digital health has the potential to improve health equity and access, but it also has the risk of exacerbating the existing gender inequities, if not intentionally designed and implemented thoughtfully. I think, and then gender disparities, I think everyone mentioned about it, that exist. We all know, we take cognizance of that, but what do we do next? And then in terms of digital health interventions, I think we also heard from Arman and then from Atipan, like there are, and then of course from other two projects also that we had like very clear benefits. But then how it is implemented, how we make sure that those inequities that could come in are actually addressed makes all the difference. And then with respect to gender bias in digital health technologies is very well recognized, and then especially how sometimes women feel excluded. And yeah. So talking about some of the frameworks and the literature survey, I wanted to actually do without this, but nevertheless, I found this study very interesting. And this is little outdated, but nevertheless, they consider these four key factors of occupation segregation, leadership, decent work, discrimination, sexual harassment, bias, and gender pay gap. But of course, this data may be more or less the same or a bit of an update, but I wanted to convey the key messages here. Women comprise 7 out of 10 in terms of healthcare workers. And women deliver global health, whereas mostly it is men who lead it. And generally, men hold most of the majority of the senior roles in health from global to community level. But I wouldn't say this is only for health workforce. Even in digital health, I've seen, even for men, it is actually sometimes difficult to move up. That's something that I would say from the personal experience, that it takes time and effort. And then in terms of women in healthcare, it is primarily women are working in primary care, nursing, midwifery, and whereas men dominate the surgery. You could see that difference. And then also, like if you see, most of the times if you just say nurse, it is understood it's a woman, unless otherwise you say a male nurse. So that way, like, there is also a bias towards the nursing. And then men dominate the senior, high status, higher paid roles. And then in terms of occupation segregation by gender drives, the gender pay gap leads to loss of talent. For example, few men entering into nursing. Just to give you some stats, this is the latest from GSMA. I think probably most of the studies are talking about the GSMA data from the last year. This is something that I found, and then I think some of the speakers already mentioned about like how many women are typically excluded, but then not all is bad. There is an improvement in the latest GSMA report, which is something that is interesting. And then the gap seems to be narrowing, but at the same time, I think Sub-Saharan Africa and then Southeast Asia is somewhere the gap still is quite evident. And then in terms of the top barriers for mobile internet adoption, which was also mentioned about digital inclusion, also a measure for SDGs or success of universal health coverage programs. The main top barriers are affordability, literacy, and digital skills. And then in terms of use of mobile, it is the safety and security, and then affordability and
just say because of the translation, they can't hear you.
Thank you. Connectivity experience, these are the barriers. And this is again a slide which a lot of stats, but I would like to draw upon this particular example of women in STEM.
science, technology, engineering, and mathematics. Here we are talking about like nothing about us without us. And then talking about gender segregated data, research. But if you see the stats, it's women are actually underrepresented in every one of them, whether it is jobs, whether it is number of researchers, are the ones who are actually holding this, getting paid well. What is that we can do? I think there are many academicians here. And then also the foundation, AHIN has been working together with the foundation to support capacity building in digital health. And I think this is one area I would say that I think we have to make conscious effort to support more women. If things, they have to be entrepreneurs, they have to be the ones who will guide the design and everything, or do research to support, but then they need to be there, taking up those studies, and then being in the job to be able to actually make the difference. So that's the reason that I thought I will also bring out this. And I think this is a very well-known phenomena. Women are inherently multitaskers. I think it's there in the genes, like we all know, our mothers, sisters, grandmothers, and everyone. They are the ones who are holding everything together in the family. And then it actually, since they do many, many, many things, it also defines what kind of jobs they will take up, whether they will do full-time jobs or part-time jobs. And then, you know, this is something, I think it also decides, like, for example, in terms of equity, men probably do not take that much of responsibility of home care or, you know, such kind of roles which women generally take. But then when it comes to performance evaluation, what happens? Women do much more, and then they have to actually match up, right? So this is something I found it very interesting. And we still work in a model where women are the homemakers and men are the breadwinners. But then things are changing. And then especially in digital health. And if this is not addressed, it's really meaningless to have gender equity being practically put into use. Again, this is what I was mentioning about. They are actually overburdened with that kind of a role, which, like for example, during COVID, like this, there was a lot of study. And then there were people who sent out surveys, and almost like, I think more than 80% of the households, it was only the women who was taking care of the things at home, like including childcare, educating them. So zero sum, I think 80%, like this is what I read, it could be a bit different. It could be 75% now, or it is improved. 80% of the top officials of all the global health corporations or companies are all men. So zero sum typically involves somebody loses, somebody wins. So in a situation when we are talking about gender equity, if we create a situation where somebody has to lose or sacrifice, it's very difficult. We can talk about this, but practically, I think it was also mentioned about gender transformative, right? So I think we need to have men involved, make them feel important, let them get that opportunity also to bring others, make sure that there is equity. I think this aspect has to be is important. And then like when we create more interactions at the professional level, it depends on how the team composition, like later on, if there is a time for a couple of minutes, I can share a simple example from their own work, from AHIN and then elsewhere. If they are actually consciously included as part of the team, consulted, made important, and then also there is a culture of frankness and transparency, rather than just, okay, there is a rule, organizational expectation, you have to comply, and then the HR briefs you. But more than that, if we make this effort to actually form a team in such a way and give them an opportunity to actually frankly share their experiences, and if they experience any bias, that actually works. This is what I mean by zero-sum, because this is a bias which is very common. And then, of course, as I said, there are many, many frameworks, and this is one of them. I found it quite interesting, but then it considers a variety of factors. So they considered, in this framework, they considered socioeconomic and cultural context, intermediate factors shaped by social context, digital determination of health, and then health system as a social determinant of health, resourcing and quality of care, digital health equity. So this is one of the models. It's also a current model. Yeah, so I'm also giving the reference. It's quite comprehensive. Yeah, thank you. It is quite comprehensive. It articulates actually several factors. The main point is we need to actually consider them together or holistically, because they are interlinked. So if we consider them holistically, then actually it has the this model, if put into practice, it has the opportunity to mitigate the gender bias. Yeah, we have plenty of frameworks, tools, but then what is that we could do in our own way? This is where I would like to actually narrate an experience in the team. Like if you look at AHIN, especially in the last couple of years, we have consciously made effort. Every single project that we do, including with our partner Fondation Pierre Fabre, we made sure it's mostly led by a woman. Or we made sure majority of them, or at least 50% of them, involve women. So these are conscious effort, including our working council members. In the last few years, we have actually increased the number of women. And then also, when we send the invitations for the conference, we also make sure that every panel is actually balanced. But then there are limitations. Like for example, we ask for a nomination to the Ministry of Health. We may not necessarily get a woman, but then we have tried to actually now specify. We try to say that, okay, we want somebody with this, and preferably we are women. These are, I would say that, small incremental steps, but we have done, and it is yielding. And right now, I would say that including our membership, and then also our working council, our trainings, all that, about 30% are women. So we hope to actually increase it, and hopefully over the next few years, we would like to bring some parity or closer to 50%. This is what I would say in our humble experience. We have tried to put the gender equity in practice. And then I would like to take this opportunity to thank Fondation Pierre Fabre, our partner, for inviting and giving this opportunity to share today. Thank you very much.
Merci. Merci beaucoup.
Thank you very much. Thank you, Jai, for these closing words. Thank you to all participants who, some of you have come from very far away to attend it. Thank you to all prize winners of these projects. We can give them a round of applause. We can also thank very warmly the whole team of Pierre Fabre for the organization of today, the selection of the theme, the choice of all the speakers, and all the logistics, inviting everyone. I thank you, the translators as well, for their work all along today. Let us not forget that this conference is available in replay on the site of the observatory. If you want to share some extracts, some comments, you can do it. Thank you to all internauts. We had more than 500 people listening to us today. Thank you for listening to us from the campuses of all over the world. Thank you to all. Do not forget to leave behind your headsets when you go away. Good evening and see you soon. Thank you very much.